जाती है, retention is little less, but this is a very pleasant reading. This is a very pleasant. You don't have that fear of examination. You don't have those targets. So this is updating yourself. The more you read, the more you update. And what I feel is this benefit is passed on to our patients.
डेफिनेटली मैडम, ये बहुत जरूरी है।
बहुत जरूरी
और पता है कई बार क्या होता है कि अगर वेबिनार है या कहीं आपको एकेडमिक्स में अदरवाइज इन्वॉल्व है, देन ऑल्सो आपको सिर पे तलवार सी रहती है तो आप पढ़ ही लेते हैं, जरूर
पढ़ लेते हैं ना, तो वो वी अपडेट आवरसेल्व्स।
अदरवाइज हम
this is the first webinar where panelists have called me that this question, the answer is not clear. This one has to be read. Anju ma'am, namaskar.
Hello, Dr. Anju, we have jumped from there to here. She's connecting.
Yeah.
बट आशा जी तो इतने सारे वेबिनार्स कराती हैं और सबको जोड़ के साथ में चलती हैं। थैंक यू आशा जी।
बिल्कुल मैम,
Great.
Welcome.
Good afternoon, Asha. How are you?
I'm good, Dr. Anju. How are you?
Great. I can see Dr. Sheila Mane joining also.
Hello.
She has joined.
नमस्कार मैम, नमस्कार।
Hi.
Sheila
Hello.
जी, आप दो
Hi,
चीज से क्यों
Kiran.
ज्वाइन हुए?
Hi, Kiran.
I have joined from two devices.
मैडम
Okay.
Namaste.
Let's just hope it doesn't
Hi.
create a problem. Alpesh sir, namaste. You're muted.
नमस्ते मैडम।
नमस्कार सर।
Good afternoon, everyone.
गुड आफ्टरनून।
So how is the presidentship going on, Anju?
Good.
Good.
Trying to make everything rolling.
Ma'am, you are doing a wonderful job. I think you are not leaving a single day of your presidential tenure.
So I am trying to make everything rolling.
Yes, ma'am. Good evening, everyone.
Welcome, Sushma.
गुड इवनिंग।
ma'am. Thank you, ma'am. Thank you so much.
Namaste, Shobha di.
नमस्ते
नमस्कार मैम।
Hi.
Good evening, Sheila
Sudha.
ma'am, Shobha
Hi.
ma'am,
Good
Sudha
evening.
ma'am.
Sudha, hello once again.
Hello, Dr. Anju, we, jumping from there.
Hello.
Hello, everyone.
Hello
ma'am.
everyone.
Okay.
Hello, everybody.
Hello, Mehul ji.
How are you, Dr. Alpesh? Dr.
Hello.
Anju, sorry.
Mehul ji,
Dr.
it's
Anju,
already
sorry.
5 o'clock. I think we should start the program. You started live streaming, just please start.
Okay. Yes, ma'am. I have made it live.
Then you need to start the program, dear.
Okay.
We are already 5 minutes into the program.
Okay.
Requesting everyone to mute themselves.
So good evening, all the delegates and faculties for the Searchlight Series 15 Core Connect live webinar, which is on the postmenopausal HRT. And this webinar is initiated by Cancer Prevention and Relief Society in association with Bhimavaram, Davangere, Faridabad, Gadag, Gangtok, Ghaziabad, Godhra, Gorakhpur, and Greater Noida Option Gynae Society. So first of all, it's my privilege to welcome our convener, Dr. Sujayashree Sangeeta and Dr. Sushma Verma. So, Dr. Sangeeta ma'am is a consultant of OBS and laparoscopic surgeon at Seshadri Hospital, and she is having the interest of laparoscopy and infertility. And madam is conducting awareness program of Vikasam for the adolescent girl, and madam is a founder secretary of Bhimavaram Ops and Gynae Society. Sujayashree ma'am?
I think she is not there.
Yeah, ma'am.
Sushma will take over.
Yes, ma'am. So I will also, it's my pleasure to introduce Sushma madam. Sushma Verma ma'am is a director and consultant of Sarvodaya Hospital and Maternity Center and Test to Baby Center. And madam is the president of Raipur Menopause Society at 22 and 24, and also chairperson of IMS Digital Education Committee. And madam is also the member of so many societies and having the interest in laparoscopic and pelvic surgery, infertility, high risk pregnancy, and menopausal health. So, requesting you, madam, please take this webinar forward.
Thank you, Mr. Mehul. And first of all, I want to thank Dr. Asha Jain ma'am for giving me the opportunity. On behalf of Cancer Prevention and Relief Society and in association with Bhimavaram, Devangari, Faridabad, Gadag, Gangtok, Ghaziabad, Godhra, Gorakhpur, and Greater Noida Ops and Gynae Society, we welcome you for this Searchlight 15 webinar on postmenopausal HRT. This webinar series deals with the important topics of Ops and Gynae, which are very important for all of us in our day-to-day practice. And this webinar series is actually the brainchild of Dr. Asha Jain ma'am. And she is the immediate past president of Raipur Ops and Gynae Society and now contesting for Food, Drug, Medico-Surgical Equipment Committee. Now I invite Dr. Asha Jain ma'am to give welcome address to all of you.
Thank you so much. Thank you so much. I think we start the program first with seeking the prayers of the divine, and after that we will start the introductions proper. So let us all pray together. Mehulji?
Yes, ma'am, just a minute.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय। ॐ शान्ति शान्ति शान्ति।
Thank you. It is a great pleasure to welcome Dr. Sheila Mane ma'am, Dr. Anju Soni ma'am, and Dr. Sudha Sharma ma'am as our guests. I would also like to welcome Dr. Shobha Guri ma'am, our speaker, Dr. Meeta ma'am as our speaker, and Dr. Rashmi Shetty ma'am, Dr. Kiran Chandna ma'am, Dr. Geeta Mekot ma'am, Dr. Sunil Patel, Dr. Archana Sharma, Dr. Ritunath Devkota sir as our chairpersons. I also welcome Dr. Priyanka Rai and Dr. Sadhna Gupta ma'am as our experts in the panel, and Dr. Vijay Kumar, Dr. Chanchal Gupta, Dr. Shruti Patil, Dr. Annapurna Dhanur, Dr. Manisha Jain, Dr. Babita Shukla, Dr. Sadhna Jaiswal, Dr. Samta Gupta, Dr. Alpesh Patel, and Dr. Alpan Agrawal from Bareilly as our panelists. I would also like to welcome Sujayashree and Dr. Sushma Verma. There's been an error in the flyer. In the Raipur Menopause Society is not mentioned, but that is very much part of this program. So Dr. Sushma Verma and Raipur Menopause Society also as a member of this program. I welcome all of you. Searchlight is a topic which we feel the participants that we need more light on this topic. And so today's searchlight will be on HRT. We have great speakers and great panelists, great experts. Everybody is great on this. And I hope all the audience who's going to listen is going to become much greater and more confident in using HRT once they've heard this. So thank you. Welcome. Welcome all of you. May I have the CV of our chief guest, please?
I would like to invite Dr. Sheila Mane ma'am to bless us with few words. Madam is at present the DNB professor of KC General Hospital, Bangalore, and she is the organizing secretary of AICOG 2003 and 2019, vice president of Fox.
Sushma.
Ma'am, please.
Just add ICOG vice chair and that is enough. Okay.
Madam is the ICOG vice chair.
Bas, thank you.
And she is
thank you, that is enough.
So many prizes and awards. And now, ma'am, please bless us with a few words.
Yeah. Thank you. Thank you for the invitation. And I must congratulate Dr. Asha Jain as well as Dr. Sushma for coming out with this excellent program. And as you said that so many people still have so many doubts in their mind before they want to start the MHT. And you have I think, galaxy of speakers and experts today who are going to throw light on that. You have speakers like Dr. Shobha Budi, then Dr. Meeta Singh, and the panel which is going to be moderated by none other than Dr. Sadhana Gupta. And I think I can see the amalgamation of so many societies from all the zones of India. That is really nice, Asha ji. South, North, East, and West. And I think you have started with the alphabeticals. So I think we are in G now, I think.
Yes.
And you have so many societies starting with G, but it's very nice, you know, because what happens is we do meet in conferences, you know, but the people from these smaller societies, I think we all are coming together because of all these webinars. And at least from COVID time, you know, we know each other now from each and every society, that these societies are also active and what are they doing. And it's nice to involve people, because everybody won't get a chance in conferences, and only the big people are invited like that. But all these webinars, you know, where everybody shares the knowledge and exchanges the ideas, will definitely go a long way. And none other than our current president, Dr. Anju Soni, who is again, you have invited her as a guest, and Dr. Sudha. And we know Dr. Sudha's association with this. And Sir also is involved equally, and their work on osteoporosis, all of us we know. And recently we had an excellent academic session even at Allahabad. So thank you once again, Dr. Asha ji. And I must tell you that it's very, very important. So I would like to say once again that CIMP exam, you know, which is the certification course started by the IMS, is very important. And I see more and more and young people joining. We started the online exams and it has become very popular. So I take this opportunity to tell all the society people who have joined here that they can access the IMS website and download the form of CIMP and fill up the form. And for before the next conference, there will be an online exam. And right now, Dr. Lashmi Ratna is the chairperson, and we had more than 100 maximum number of candidates appearing. And that itself will clear your doubts, you know, because you are going to read this subject from the bottom of your heart. And examination is just, I can say, just one way of making people really read about the problems and clear their doubts. And at the end of the day, I must tell you, you know, it helps you to treat your own patients. You treat them in a better way, okay? And then you are happy that you are able to treat your patients, and the patients come back and they tell you that, madam, I had so much of problem, because, the women in our country are still not aware, and they are going through so much of menopausal problems. So I must tell you, I have a standee put up in my OPD. Okay. The mother or mother-in-law accompanying daughter-in-law, they themselves come when they walk in my chamber, they themselves ask about that. So it's very important that we spread more and more awareness, not only amongst doctors, but amongst the communities also, to see to it that we really have a healthy population, as we know that the life expectancy is going up, and we have to see that all women are fit at 40, strong at 60, and independent at 80. So thank you once again, and wish you all good luck and congratulations for this, Ashaji. And also good luck for your future endeavors.
Thank you. Thank you, Sheiladi. And I'm moderating the panel.
Yeah, ma'am is the moderator for today's panel.
Yeah, both of your moderators, Dr. Sadhana is the expert. Yeah. Can't hear you.
Asha, your
Sadhana ma'am is the expert, ma'am.
Yes, that's what I said. She's the expert. You are the moderator.
With lots of gratitude and respect, I invite Dr. Anju Soni ma'am to say a few words of blessings for all of us. Anju ma'am. Anju ma'am is the vibrant president of IMS 2024-25. She is the Secretary General of IMS. She is the past Secretary General of IMS 2022-23. And she is the elected Governing Council member of ICOG 2023 and 25. And we all know Anju Soni ma'am very well. She doesn't need any introduction. So welcome ma'am, and I invite you to say a few words of blessings for us. Anju ma'am.
Thank you. Thank you, dear Sushma, for your kind words. And first of all, I would like to congratulate Dr. Asha Jain, who has been tirelessly working on this series of satellite webinar, which I have been seeing in last so many months, where she has really worked hard, and she's brought beautiful faculty, very well learned faculty from all over the country. And I always feel that learning is very important part of everyone's life, especially doctors. We need to keep abreast with the learning, and it is so very much important for all of us. And when we talk of, say, menopause, there are lots of myths and misconceptions, and lot of people are scared to give menopausal hormone therapy, which is so very much important and is required in many cases, and where the women are not being provided with this therapy, which is so helpful, not only for specific symptom, but also helpful as along with that symptom with all other comorbidities which she may develop, like started in time, they can help a woman prevent her cardiac problems, even help her with glucose metabolism, and many more things, along with osteoporosis. So we should give them as and when required. And I would also like to and we all know that there are 1/3 of a population, not only in India, all over the world, who is in this area where they are having the problems of perimenopause and menopause. And all these problems are preventable and can be treated with timely interventions and timely treatment. And I would like to thank Sheila Mane for taking over a very important subject, CIMP, which is now so very important. And it's we are giving study material also to the people who are appearing, and it is kind of revision and kind of knowing the subject in depth, and it is not that difficult. With the Dr. Ashwini Bhalaro as our new chairperson of education committee, we are looking forward to more and more participation. And these CIMPs, their names are going to be there on the website of Indian Menopause Society, and that will again help in their practice. And I would like to also welcome all the delegates who are here today, and all my colleagues who are there, Dr. Sudha, Sharma, who is there along with me, and then beautiful conveners, Sushma and Sangeeta, and also the speakers, Dr. Shobha Giddy, who has been also working very hard, and chairperson, Dr. Reshmi, and Dr. Kiran Chandana, who is again a very active member of Indian Menopause Society. Dr. Meeta Singh doesn't require any, she has been known as a menopause teacher for each and everyone. She's teachers of teachers. And Dr. Patel, we all know his work is what he has done for osteoporosis. And Dr. Archana Sharma and Dr. Ritu Nath, who are there as chairpersons, I'm sure they will throw light. And of course, Asha, we all know her diligent and hardworking, along with the Priyanka Rani and Dr. Sadhna as experts, and all the panelists which are there from all the parts of G societies of India, Dr. Vijay, Dr. Chanchal, and others. I'm sure they'll be able to throw a lot of light on this topic, which will be beneficial to all the people who are here. So thank you. Like to congratulate once again, and my wishes are always with Dr. Sushma for all her endeavors. Thank you, Sushma.
Thank you, ma'am.
Thank you, Dr. Asha.
Thank
Thank you, Dr.
Anjali.
Asha.
Thank you. Thank you.
Now I would like to invite our guest of honor, Dr. Sudha Sharma ma'am, to share a few words of wisdom with us. Sudha ma'am, over to you, ma'am. And Sudha ma'am is the Vice President of IMS 2024-25. She was the Secretary General of IMS 2000.
Thank you, Dr. Sushma.
Ma'am, there is a lot to read in your CV.
Thank you so much for those kind words.
And we are blessed to have such stalwarts of IMS in this webinar. Thank you very much for coming, and please bless us with few words, ma'am.
Thank you so much. Thank you, Dr. Sushma, for those kind words. And a very good evening, everyone. So at the beginning, I really want to congratulate Dr. Asha, and everybody has said so, for conducting this series of, Searchlight webinars. And Dr. Asha, what a great idea, bringing so many societies together on one platform to learn and to know each other as well. So probably today is the 15th one. And thank you, Dr. Sheila, also for inviting people to join Indian Menopause Society and take up the CIMP exam. Dr. Sheila, I still remember those times when you were chair and I was the Secretary General, and we had made that small group of CIMP candidates. And it is, so nice and lovely to see all young people, joining Menopause Society. So that gives us immense pleasure. And Dr. Asha, you have chosen this important topic, such a debatable topic. The more we read about it, the more we learn about it, the more we hear about it, the less it is. And it has become debatable, more after Women Health Initiative study. And, the consensus which has been made post WHI, the guidelines given by various organizations, still there are indications of MHT. And we are going to hear this from our wonderful expert, stalwarts, lovely speakers, the chairpersons, the conveners, the moderators, and the panelists. You have invited a galaxy of stars, Dr. Asha, and thank you, Dr. Sushma. Thank you so much for inviting me, Dr. Asha, over here. We are here to learn and to hear more.
Thank you, ma'am. Thank you, Sheila Di. Thank you, Dr. Anju. Thank you, Sudha ma'am, for being here. And whatever time you have, if you can stay on, because in the panel, I have taken 14 situations. And if you can have experts, it's going to be rapid fire, because it's like 3 minutes per case, but we want the gist of the matter. If you can stay along, you're most welcome, and we would be really grateful. If you cannot, then namaskar. So, Mehulji, may we have the chairperson CV, please? Over to you, Sushma.
Moving forward in our scientific session, for our first lecture of today's webinar on HRT in intact uterus, I would like to invite the chairpersons for our lecture, Dr. Rashmi Shetty. She is the consultant and director, City Hospital, Devangiri, past president of Devangiri Obsgynae Society 2022-23, vice president IMA Devangiri 2022-23. And then I would like to invite Dr. Kiran Chandana, Director Chandana Medical Center Faridabad. She is the president of Faridabad Obsgynae Society and member of Foxy MTP committee. And then I would like to invite Dr. Geeta Mekot. She is the consultant gynecologist, AKG Memorial Hospital, Kannur, President Kannur Obsgynae Society. Welcome all of you, ma'am. And I invite Dr. Rashmi Sethi, ma'am, to introduce our speaker, Dr. Shobha Goody, ma'am.
Good evening, everybody. It gives me immense pleasure to introduce Dr. Shobha, madam. I was closely associated with her during the elections last time. Madam is the chairperson for Contraception and Reproductive Health Society and also the ISIT member for Kasoga 21-23. She's been the editor for Obstetric Hemorrhage book publication by national and international levels. Madam has received many awards and the C.L. Javeri Symposium 2015 AICOG, the Best Society for BSOG and Kasoga 2018. And Madam is now the professor and HOD of St. Philomena's Hospital and a postgraduate teacher. She's president BSOG 1819 and assessor for GOI project Lakshya. Madam, please share your immense knowledge with the entire group here and welcome, Madam.
Now I invite Dr. Kiran Chandana ma'am to introduce about the topic in a brief.
So the topic is hormonal therapy in intact uterus, and because we are always in a dilemma whether to give hormonal therapy or not, and even the patient they ask about it, and because in 90s, in early 2000, the hormonal therapy was banned, so there is fear in our minds that they have whether to give it or not. And also the availability of hormonal therapy is also issue. So sometimes we don't get it, and so we are going to learn about this from our expert. I welcome Dr. Ma'am to initiate her talk.
Thank you very much, Kiran, and thank you so much, Rashmi. It was nice to connect online, and it's wonderful to see people from all across the country joining here. And I think that is the great enterprising mind of Asha Jain, which has brought us all together today. It's really wonderful, Asha, to be with your, with your connect, with your abilities to be able to speak to so many people. I have a confession to make before I start sharing the slides. And I must tell the stalwarts, Dr. Meeta in particular, Dr. Meeta Singh, big namaskar to you. I hope you are listening in. And Dr. Sudha Sharma, Dr. Anju Soni, all the great minds in menopause, but I probably know much less than you about this subject. But since I was invited by Asha, I could not say no. But I should have looked at the flyer, I think, and then I might have told her that maybe it will be kind of difficult to speak in front of, especially Meeta, who was herself responsible for making the guidelines for Indian Menopause Society. So thank you very much for this opportunity. I consider myself blessed. And with that, I shall go ahead. And Dr. Sudha, your work this year is so rich. I'm thinking next year what will happen, because you have your presidential year coming up.
Thank you, Dr. Shobha. And don't think like this. You are a great orator. You are a great orator. We all have listened to you.
Thank you, sir. So I will try and share. And before that, of course, I must also thank Sheila for making time today and saying all those kind words, and also Dr. Anju for taking time off from her busy schedule and being here. But most important of all, let me tell you that I have seen Asha for many long years. She was 2 years junior to me in college, and the kind of culture, tradition, and the academic, the aspirations which I have seen inculcated in her from the very beginning, I feel that she has a great future in whatever she does, and I really bless her, and I wish all the very best for her. So, Asha, uh, please never lose your courage. Always be there. So, you have asked me to speak on mastering menopause management with tailored approach for women with intact uterus, and I will try and do some justice to it. Now, usually when we speak in such sessions, we actually start from, what to expect in a woman who walks into the clinic seeking care for menopause. And then we touch upon the therapy. We say about tailoring the approach. We also try and share some clinical data, especially on safety and any other benefits that the therapy may have beside the menopause symptom alleviation. And of course, we need to apprise the audience that there are very strong guidelines and recommendations today, and I will be coming to that. Okay? So, when a woman, for example, a 47-year-old, very well-read woman, a leader in her own right, comes in with some menstrual disturbances on the lesser side, less frequent, less slow, about some body ache, about some fatigue. She also says some hot flushes, some disturbed sleep, some mood swings. Maybe something is left untold also, like sexual difficulties, also complains of less performance. And you can see that all these are very subtle. And if she goes to a physician, she'll get dismissed out of hand. She will be told to take some B complex. And if the BPs and sugar and the thyroid are normal, they're likely to say do a mammogram and a pap smear and keep quiet because everything is okay. But then we know, and of course the hemoglobin, but we know that the story is beyond that, and that she requires more help than what an average physician can give her, in spite of all those parameters being normal. The uterus is intact, and this woman has no significant family or significant personal medical history. And so we need to understand that she is going through menopausal transition. And I appeal to all the clinicians, all the gynecologists who are dealing with women to think about menopause as a transition and not about only the final menstrual period. We need to understand that the woman starts feeling the deprivation of the estrogen, especially a few years before the final menstrual period, and then the effects of deprivation last for much longer after the final menstrual period. So charts like this will orient us to what is happening. Now, what is the quantum of this kind of clinical situation, and why are we so concerned as menopause practitioners that we are understating, under-addressing the situation? If we look at the US, they have a good quantification of the burden that they have. They say that, approximately 1.3 million women are menopausal each year. Now, in India, the approximate number is very difficult to define, but I have a good suspicion that it might be 130 to 150 million because, after all, our population itself is about 1.44 billion. So we are 100 times the burden that the United States can have in a much smaller country with much less health resources. Okay, so we also need to know that, some women already start the symptoms between 40 and 45, and they suffer silently. And some of them are before the 40 years, about 1%. But on an average, we say that women spend less, about 1/3 of their lifespan. Is that true? If you think about it carefully, they are spending more than that of their lifespan in the postmenopausal stage, because today longevity has improved and we are looking at 40 to 45% of their lifespan after menopause. And that means that they require a lot of care. There is some estimation that 2025 will see 1 billion women in the world experiencing menopause. That's okay, 12%, and that is expected. In India, the estimated age is 46 to 47 years, and we are lower than the rest of the world. And that is again significant because it again means that we have a larger burden of menopausal women because we are experiencing it at a lower age. So one good thing would be to get familiar with the stop-loss and stadium system, because it indicates, the time before the final menstrual period and after, when women require very sensitive care, and to understand the transitional changes. The perimenopause is early and late. It can be a little variable, 1 to 3 years. The immediate, premenopause is interval of the perimenopause is where there is extended periods of amenorrhea with less frequent periods. And then finally comes the final menstrual period. And after that, the immediate 2 years is early menopause. Still, there is a great deal of window of opportunity available for us in these 4 to 5 years to put in some corrections and to put in some good management, so that this time for the woman, the remaining time of her life, is really having great quality. So that is what is our intention in understanding menopausal transition and beyond. And we must know that though the symptoms may start like vasomotor and sleep disorders and mood changes, which are a little obvious ones, menstrual disorders, which are more reported ones, what is more damaging to a woman's quality of life is the urogenital atrophy, the sexual disturbances, and the very horrible symptom of urgency and stress incontinence. And the hidden one, about which Dr. Meeta will, I'm sure, speak extremely brilliantly, is the osteoporosis. And the even more hidden one is the atherosclerotic damages of the vessels, because we are as healthy as the endothelium of our vessels. And that is what gets taken away because of menopause, resulting in coronary artery disease and cerebrovascular disease. There is good evidence today that if this part of life is good, well managed, because this is a window often missed, even I have missed this window, we will land up with more atherosclerosis later in life, and that is very likely with most of our women. So having said the basics, I'll go a little faster now. So the reduced estrogen impacts many organ systems, results in wide-ranging menopausal symptoms. All this I have already said. There can be some palpitation, frequent urination, so the silent bone loss. What is the discomfort? Some joint pains, of course, dryness of the past, headache, dysuria, dyspareunia, everything. Neurological will result in loss of libido, which adds to the local dryness. Please remember, sexual difficulty is twofold. One is local and one is central. And there can be other problems, mainly stemming from the lack of sleep and the low self-esteem, which is coming because of the gradually waning estrogen levels. So there is sleep disorder, there is depression sometimes, memory lapses indicating cognitive deficiency. Please be very, very alert when this happens. It can indicate more, severe problems later on. And the skin and the nails and the hair and the weight gain, everything adds to the body image of the woman. And unless she is very proactive about it, she will end up feeling low because of the altered appearance. So then we start with giving them healthy lifestyle, for better transitional, experiences. We tell them to change the lifestyle. That is the one. We tell them to become a different person. No longer only tending to the in-laws, to the husband, to the children. Do that also, but then look after yourself better so that others also realize that your health is important. So exercise, some other hobby, becoming more of an extrovert, less of substance abuse, etc. Take regular supplements, and then get assessed for hormone therapy. Should be always, given whenever it is indicated. So the message here is every woman in menopause may not require MHT, but those women who require must be identified and it must be provided. So the pharmacological options for the symptoms which we discussed could be hormonal, could be non-hormonal, and to the centrally acting agents could be given, which are antidepressants also. Some of the anti-epileptics also may help in vasomotor symptoms. Gabapentin, pregabalin also have been used. Fluoxetine is very commonly used, so also is sertraline. And then there are complementary and alternative therapies like phytoestrogens, isoflavones, which are also being used, but the data are insufficient. And today we shall be speaking only about the MHT. So the use of MHT in the treatment of menopause actually took a big hit in the West, because in the East it was never that much prevalent, but in the West it was. took a big hit because of the WHI report. And all of us have read about this in our postgraduate days and immediately later, that because of this study, it was thought that menopause hormone therapy can reduce the lifespan of a woman, can cause stroke, can cause heart attack, can cause breast cancer, etc. Concerns about breast cancer and cardiovascular risk have caused many symptomatic women to discontinue or never request MHT, resulting in increased VMS, insomnia, and osteoporotic fractures. So how deadly the outcome was, it really compromised the women. So removing the cobweb of myths of which the WHI created. And what was the model? It was a very improper study. It took older women, some of whom were smokers, 50% were smokers, quite a bit obese, who had previous cardiac disease, and only few drugs were used, like conjugated estrogen and medroxyprogesterone. And there was inter-investigator conflict, right? And it was a very generalized kind of result. And the younger women, estrogen-only HRT were not picked up initially. It was only later on, when the meta-analysis started getting published, that people realized that it is the progesterone which is the culprit for causing the breast cancer, not the estrogen, etc., etc. So MHT today, evidence says that it's the most effective treatment for menopausal symptoms. Okay, reducing hot flashes and sweats, night sweats, positive effect on other symptoms, on mood swings. It removes the peeling down sensation, dyspareunia, first-line therapy to prevent bone loss in postmenopausal women, which will be spoken of again. All right, and in much better way than what I am doing. Estrogen remains the most effective treatment for vasomotor symptoms, right? Endorsed by almost every statutory authority on menopause. The International Menopause Society, the North American, the British Menopause Society. Genitourinary symptoms also, bone loss prevention also. And whenever there is symptoms, it can be started. Well, and NAMS says less than 6 years, less than 10 years of onset. BMS also says that is British Menopause Society with symptoms. When to stop? North American says for 10 years, there is no arbitrary limit by others. The dose, lowest appropriate dose, and no arbitrary limit. So maybe we are looking at appropriate. So we need to look at all the guidelines, individualize our therapy for our women, and we go ahead. But we never deny the service. That is important. MHT alleviates the typical symptoms, improves bone mass, most effective. I'm repeating, but I thought that this was a very figurative, very nice kind of slide. Okay. I am particularly interested in giving you the message in this part of the slide. Of course, this phase reduces the fracture risk. That is very important. A 30% decrease all-cause mortality. Now, believe me, audience, this is very well proven today, and 48% decrease in the coronary heart disease risk. So this is all proved by evidence. MHT started within 10 years, after menopause, reduces the risk of all-cause mortality and coronary heart disease compared with placebo or no treatment. So 10 years post-menopause is the limit. Beyond that, and also the other number to be remembered is 60 years of age. We'll come to that. So guidelines and recommendations. As I said, I showed another slide. So this is supporting that. This is 2016 International Menopausal, 2017 NAMS, 2020 BMS for British Menopause. Okay, so you can see that all this I have already spoken about, that there is lowest effective dose here in IMS and annual consultation. Here it is periodic assessment and appropriate dosage. And this is according to severity, and then safe to use for at least 5 years. Here it is individualized, and British says arbitrary limits should not be set in. Now, risks and benefits differ during transition compared with postmenopause. So slightly different dosages earlier. In general, women, as they become older, it is important to keep the dose at a lower and lower level. Benefits will more likely outweigh risks for symptomatic. And so it is important to identify symptoms for which you are going to prescribe. Favorable benefit risk profile when prescribed before the age of 60. So here the magic number 60 comes up. So remember that. Now, this is the recommendation from Indian Menopause Society, and the author name is not seen here, but Dr. Meeta Singh is one amongst the author. So with all salutations to you, I must say, estrogen therapy approved by FDA for treatment of vasomotor, patients with persistent severe hot flushes, most effective, should be used for the shortest duration, short-term use less than 5 years, not associated with significant risk. Please remember this. Estradiol is the first line estrogen, oral or transdermal. So it's estradiol, not ethinyl estradiol. It is just estradiol. Okay. In a cyclic regime, progesterone should be added for minimum 10 to 14 days with women with intact uterus. Only very small percentage continue to suffer from hot flushes 10 years after. Therefore, longer HRT may be appropriate depending on the benefit versus risk profile. So every time, try to do this benefit versus risk profile for your woman. Treatment should be periodically evaluated. This is what I meant just now, what I said. Okay, because vasomotor symptoms will definitely abate over time. And therefore, we can even stop if it is because of for that we are giving. While prescribing, contraindication and adverse effects should be kept in mind. So the message here is a constant revisit to the decision for continuing the HRT. So call her every 6 months, rule out contraindications, check if she has developed any NCDs in the meanwhile, any other risk in the meanwhile, and then take it forward. So this is in brief, it is age is a major determinant. Less than 50 years, the benefits far outweigh the risk. HRT should be offered. 50 to 60 years, benefit outweigh the risk. HRT should be offered nevertheless. Okay, and more than 60 years, the risk will be equal or outweigh the benefit, and treatment should be individualized. So the tailored approach means that progesterone should be added to prevent estrogen-induced endometrial changes, which can result in hyperplasia and sometimes in malignancy. And the type of hormone therapy a woman receives will therefore depend on whether or not she still has the uterus. Who still has the uterus with estrogen plus progesterone, and who have had hysterectomy can be offered monotherapy with estrogen. And suppose there has been an endometrial ablation, again give progesterone, because some endometrial tissue may remain and may become malignant, and it will be very hard to diagnose. MHT is most effective for VMS, seizing the window of opportunity. So if you start within 10 years or below 60 years of age, you are going to get good maintenance of estrogenic benefits, reduced all-cause mortality, no increased cardiovascular risk, and a reduction in fracture risk. So please remember this slide. This is a slide which is showing estrogen progesterone. You can see this is sequential. You have given estrogen for 28 days and you have given progesterone for 48 days. So this is sequential, and she will get at the beginning of the bleeding, at the end of the cycle, she will get some bleeding, and then you can restart the estrogen. If it is continuous combined, both, then there is no bleeding. Continuous, both estrogen and progesterone are given daily, resulting in amenorrhea. Whereas here she may have scheduled bleeding. There's one more to explain it better. Now, if there has been no hysterectomy, just focus here because today's talk is on that. Give both. In perimenopausal women, sequential therapy is better because they're still having periods. Postmenopausal, continuous combined can be chosen so that they remain period free. And the estrogen, which can be given oral or transdermal. Okay, both are available with a range of types of progesterone. And here there are indications for transdermal estradiol therapy, which I would prefer to finish before we go ahead. So individual preference, poor symptom control with oral DIH, it is there. If there is previous or family history of VTE, if its BMI is more than 30, variable blood pressure control. If there is migraine, current use of medication that induces the hepatic enzymes, and if there is gallbladder disease. So in all these women, transdermal is better than oral. And if you choose transdermal and the uterus is still intact, still every cycle for a minimum of 14 days, one can choose to give an oral progesterone so that she can still have, the benefit of periodic progesterone along with this continuous. Hopefully a transdermal option will come for progesterone also in future. So let us look at this part of the graph where cyclical estrogen. Can you see that estrogen is being given for 21 days and progesterone for 14 days, and there is a 7-day break and a cycle. And there is this estrogen for all 28 days, and from day 14 progesterone. So this is again sequential. The progesterone is given in the second half without a tablet break. You can stop both here and she can have regular bleeding here. Continuous is when she goes on taking both without a tablet break, no bleeding at the end of the cycle. So this is how it goes on and on. Okay, so that is how. It is important to be very, very familiar with the molecules that you're prescribing. And here I must mention that it's very important that we know about the availability of the medicines that we are prescribing. It should be easily available. And the second thing is that the woman should find it affordable. So these availability and affordability are two things that you have to check from the patient's point of view, acceptability point of view, and from our point of view, we have to think about the indication and also about the benefits, the benefit risk ratio. So let us understand that all estrogens are not the same, and currently we are sure that everybody knows about conjugated equine estrogen, which is a complex compound with a little less bioavailability, and we have a synthetic estrogen, which is ethinyl estradiol, which is not much used for NHT, only for kind of contraception. But what is important is the natural estrogen. In any which form, this is going to be beneficial for the woman, which is just E2. So does the estrogen matter? Yes, it does matter. And we have today estradiol valerate also, and we have micronized 17 beta estradiol also. We have conjugated equine estrogen also. The cheapest amongst them is the CEE. Relatively increased effects in certain parts of the body like the liver, and it has relatively little higher risk of metabolic effects than the other two. But in a carefully selected patient, we can of course use CEE also. But the preferred one would be estradiol or the micronized 17 beta estrogen. Okay, so this is how it goes. The choice of estrogen in MHT matters. I have tried to put some evidence here which shows for bone endpoints. I think this will be better covered in the next lecture. I shall quickly go ahead, but you can see that the recommended lowest effective dose for bone health is like this, and 17 beta estradiol 1 milligram, valerate also 1 milligram, and transdermal actually is, if I'm not mistaken, 1.53 milligrams per day, but this is a different compound which has been mentioned here. What is available is that. Now, estradiol benefits on BMS. This is a very good slide because it explains to you that in comparison with placebo, how do the estrogens stand for reducing the hot flushes. And we can see at 12 weeks, what is the effect, and at 4 weeks, what is the effect. And you can find that very low doses of estradiol 0.25 milligram will not help. But when it improves to 1 milligram, the effect is substantial. The difference between 1 and 2 is not very great in terms of 4 weeks outcome, and we can opt for 1 milligram whenever it helps to reduce we can at least try with 1 milligram before stepping it up to 2 milligram. So this is again oral versus transdermal estradiol, because the transdermal essentially has the first pass effect. And so you can see that there is a benefit in cholesterol levels, triglyceride levels. The procoagulants are less here as compared to oral. The SHBG is only minimally increased. Okay, so it doesn't much bind with the androgen, and therefore not much change in the libido. The blood pressure is hidden. Actually, there is no effect on the blood pressure. So we'll go on. Not all progestrogens are the same. This is a very familiar slide which we use for contraception also. I just want to bring your attention to these two. I'm so sorry. Only these two, the dihydrogesterone and the natural progesterone. And you can see that, we will be seeing that better in the next slide. So I'll skip this slide. We must understand that progesterone acts through like this receptors. Of course, even estrogen acts through receptors, But we need to have good understanding of receptors, where all there's a membrane progesterone, the cytoplasmic receptors, the nuclear receptors, and then different progesterone acting over the mineralocorticoid receptor, the progesterone receptor, the glucocorticoid receptor, the androgen receptor, right? And so on and so forth. So there is a very strong element of receptor activity as far as progesterone is concerned, and the biological activity depends on the chemical structure and its occupation of the receptors. So here we can see that the dihydrogesterone is mainly progestogenic, and anti-estrogenic action is also there a little bit, and anti-androgen action is also there, anti-mineralocorticoid, but it does not have estrogenic effect and no androgenic effect, and it doesn't have glucocorticoid activity and does not block ovulation at therapeutic doses. Dihydrogesterone seems to be selective for progesterone receptors, and therefore it will particularly protect the endometrium when given in women with intact uterus. So these are some clinical data of estradiol and dihydrogesterone, because that was what was available. So I have put it, but this will not help us to get through this lecture. I'm just putting it as evidence that its efficacy has been proved with very many multicentric studies of estradiol plus dihydrogesterone. So both sequential and combined. So instead of going through all the data, it's just enough to know that there is enough data. And even the continuous treatment is having good amount of effect. So we need to kind of tailor it to the need of the woman rather than, so older women who do not require periods can use continuous treatment, and it improves vasomotor symptoms, right? Okay, so I think I should get ahead here. Sequential estradiol and dihydrogesterone 1 and 10 improves vasomotor symptoms very strongly. And why I put this symptom is this is having that the green climacteric symptom scale. So it's always good to have some kind of validated tools to assess the response to treatment. I think Dr. Meeta will tell more about this in some in other lecture maybe, or today also. So the green climacteric symptom scale is one of such validated tools. So when we put them on treatment, when they come back to us for follow-up, we can actually assess how much benefit they have had. So what about the quality of life, sexual function, and other menopause-related symptoms, such as pains and aches, mood changes, may improve during MHT. And genitourinary symptoms also have 40 to 60% of women will suffer from this, and significantly adverse effects on women's sexual health also result as a result of the GSM, and that is why the dryness, itching, burning, irritation, decreased orgasm, postcoital bleeding, dysuria, a hell of a lot of symptoms are there. Sorry to use the slang word, but it is really hell for a woman who is going through it. And the vaginal atrophy can have a kind of, very significant impact on the mind as well of such a woman, and therefore we must help her. And here local estrogen will also help. So we have good evidence that every kind of MHT, let it be oral or let it be local or let it be even tubolone, is effective in the treatment of vulvovaginal atrophy, and it should be considered in local low-dose estrogen therapy is preferred if symptoms are limited only to dryness or to discomfort, and for prevention of recurrent urinary tract infection. Kindly please remember this, because sometimes they do not report the sexual symptoms, but they keep on coming with recurrent UTI, and in them also, in addition to UTI treatment, this may be required. All right, so this is more study. Okay, so about the psychological benefits of MHT, resilience factors get affected during menopause. However strong a woman is, even though she may be Jhansi Ki Rani, she will suffer during this transition some amount of emotional deprivation, some amount of cognitive impairment, and her coping strategies will definitely get challenged, if not impaired. And the psychological maladjustment can lead to more secondary effects. And the resilience factor, which women are often known for the like hardiness, coherence, meaningful life, spirituality, emotional stability, everything gets that balance. And that is what we have to strengthen. Okay, so depression and menopause association, and estrogen increases the effect of serotonin and norepinephrine, and therefore there is a strong role of MHT. The cardiometabolic effects, there is an important timing hypothesis for cardiovascular disease risk, because there's a lot of confusion that if you give MHT to women, will it cause them to have more heart attacks or stroke, which is not true. MHT started in perimenopause, that means before menopause or early postmenopause, it's cardioprotective. Whereas it is late after menopause, increases the risk of cerebrovascular disease. That is what we have. So MHT started within 10 years after menopause, reduced the risk of all-cause mortality, including coronary heart disease. And this I have repeated because I feel it needed to be repeated. Okay, and to understand this kind of relative risk and the ratio and the 95% confidence interval, you can see this favors treatment. Anything to the left of this central line indicates favorable, key that it is important to treat them for this. So all-cause mortality is favors treatment. All-cause mortality within 10 years after menopause, it showed a reduction in all-cause mortality.
So, ma'am, please conclude.
Yeah. So I'm concluding now because I think I will not be able to take you through this. So these are my concluding slides. Okay, this is for osteoporosis, which Dr. Meeta will speak, so I can again conclude on that. And this is on VTE. So this is on a woman who has had breast cancer, will be covered in the panel, I have no doubt. But I must say that estrogen, does it cause breast cancer? What will you advise if there is a family history of breast cancer? And what about other cancers? So I just want to share one interesting fact before I conclude. The increased risk of breast cancer primarily associated with risk of progesterone. Okay, but the risk is dependent on the specific progesterone use. That also is important. So when we come to the safety factor, the risk of breast cancer attributable to MHT is small, and the risk decreases progressively after the treatment is stopped. Okay, breast cancer risk should be evaluated before MHT prescription. Now, this is the bottom line is very important. Always evaluate the risk, and this is a good slide to remember. It's a good slide to remember, and the pink shows the baseline risk in women without menopause hormone therapy. And this shows, this is with 95% confidence interval, so very acceptable, though it is done in 2009. It's a Finnish cohort study. Now, estradiol and dydrogesterone, this is use of therapy for 5 years and more. And we shall only these two, we will not go beyond this. Okay, we'll only these two, estradiol, dydrogesterone. So only a little bit more. But when it is estradiol and MPA, medroxyprogesterone is so much more. So I think we have good reason to believe that medroxyprogesterone acetate, I think we should not use for MHT anymore. Breast cancer risk may not be uniform with all progestrogens is another study, the French cohort study, almost says the same thing. Now, this is an important slide, and I always like putting slides, putting risks of MHT into perspective, okay? All right, so let us look at 23 cases of breast cancer diagnosed in UK. Combined MHT, if you give a combined MHT to them, there are 4 more cases. If you give estrogen only MHT to them, there are 4 fewer cases. If they are obese more than 30 BMI, there are 24 more cases. If the alcohol 2 or more units per day, 5 more cases. If combined hormonal contraceptives, there are 4 more cases. If current smokers, there are 3 more cases. And if 2.5 is moderate exercise per week, it's 7 fewer. So there is a high role for lifestyle modifications. So if we were to combine the MHT and the exercise, probably we are going to get fewer cases. That is the message I wanted to give. And look at the weight. look at the weight, if we kind of control the weight, if we reduce the BMI, we get a lot less cancer. So that is what I wanted to give, and this can be used as a counseling tool while prescribing MHT, and we can tell that if they are obese, they have to reduce weight, etc. Again, these are other cancers, and we can see that with no HRT, the cancer of endometrium, ovary, etc. has been reported to be higher than when there is MHT, and the pink is estrogen plus progesterone. So the pink is the least endometrial cancer, etc. All right, so lower risk of VT is possible through with transdermal therapy. So in women with high risk, please consider transdermal. This is again the risk of VTE, and the favorable confidence interval and risk adjustment is with dydrogesterone and micronized progesterone. Okay, so let me just conclude. I will not do premature ovarian insufficiency. It is for another time. Okay, and I'll not do unscheduled bleeding. So in summary, it is very effective treatment. No significant increased risk of breast cancer who start the treatment between 50 and 59 years. Oral is not associated with significant increased risk of venous thromboembolism. Both estrogen and progesterone and dydrogesterone and micronized progesterone both are favorable to you. So there is a significant benefit. And non-significant risk, okay? Benefit outweighs this if proper case selection is done. And these are the benefits which I have already spoken about. And the risks are very, very rare with dydrogesterone and micronized progesterone. And with estrogen, it is all ill-founded and mythical that there is risk. Because if given at the correct time, there is more favorable, less than 60 within 10 years of menopause. Less favorable is the reverse. So in summary, the primary goal to relieve hot flashes, vaginal symptoms, DSM, sleep, depression, anxiety, joint aches and pains, grade 2B recommendation. For most women, the benefit outweighs the risk. Exceptions, history of breast cancer, coronary heart disease. So here comes your checklist. Have this checklist. In these people, in these women, please be very careful and try to look for alternative therapies. Previous VTE, active liver disease, and those at high risk of these complications. The message is not to deny them help, but to look for other venues of help. Duration, 3 to 5 years, maybe 5 years is good. Women with premature ovarian insufficiency, please give an MHT, at least till age 50 years. No MHT for prevention. Okay, this I will leave it. I'm not very confident about this. The use of estrogen within first 10 years may reduce the risk of CHD and mortality. The transdermal route I have spoken about. 17-beta estradiol is preferable. The baseline risk of VT and stroke very low in otherwise healthy women. For women with intact uterus starting MHT, we suggest micronized progesterone or dydrogesterone. So with that, I rest my case. Thank you so much. I'm sure I exceeded the time, and for that I speak here. Pardon.
Thank you very much, ma'am, for a very wonderful and elaborate lecture. Now I invite Dr. Geeta Mikot, ma'am, to say about the concluding remarks.
Geeta ma'am, you're muted. You're muted, ma'am.
Good evening to all. Canon Society is privileged to be here on this platform. HRT was a gray area for all of us. Due to lack of focus on HRT, most of us, ladies including gynecologists, do not get the much needed HRT. Thank you, Shobha Madam, for throwing light into the unknown areas. We have to initiate and continue MHT. I happened to be in IMS National Conference in Calicut and learned so many things from that. That's why I told Asha ma'am, thank you so much. You were so prompt. Made this HRT webinar possible so soon. I asked her last week only. Thank you. Thank you so much, madam. Stay blessed, madam.
Thank you so much. We have actually exceeded the time by 25 minutes. So request all the panelists, let our answers be really quick. We will be just rewinding the different situations. We would not be repeating anything. So now I invite Sushma. Please invite Meeta ma'am. It's an honor to have her here. For the first time, I got a message on my WhatsApp from somebody high up in Foxy. You have chosen the best speaker. So thank you, ma'am, for accepting. And over to you, Sushma.
Welcome, ma'am. Welcome, Meeta, ma'am. You are a stalwart of IMS. It's a proud privilege for me to host this session where such dignitaries are on the dais. For the second lecture of today's webinar on bone health and calcium supplementation in postmenopausal women, I invite chairpersons for the lecture, Dr. Sunil Patel, sir. He is the consultant obs-gynae and laparoscopic surgeon, Navjeevan Hospital, Lonavada, Gujarat. Dr. Archana Sharma, consultant and scientific director, Ganesh Hospital and Test Tube Baby Center, Ghaziabad. And she is the president-elect of Ghaziabad Society 2024-25. And Dr. Ritu Nath Devkota, chief consultant, STNM Hospital, Gangtok. And he is president of Gangtok Obs and Gynae Society at present. So welcome all the chairpersons, and I invite Dr. Sunil P. Patel sir to introduce our speaker, Dr. Meeta ma'am.
I don't think Sunil sir is here. Any of the chairpersons who's here can
I
take up.
Dr. Archana Sharma ma'am to invite and give a brief idea about the lecture.
Thank you, madam. Thank you, Dr. Asha Jain, for considering me to share this session. I am highly privileged actually to introduce our esteemed speaker, such as stalwart in Foxy, Dr. Meeta. She is the consultant head OBGY specialist in menopause and osteoporosis, and she is the co-director Tanveer Hospital. Areas of interest are definitely postmenopausal osteoporosis, and she is the founder chair, Indian Menopause Society Registry 2021 to 2031. And a lot of many awards are to her credit, like Editor Journal of Midlife Health 2020-2022, then Chair Clinical Practice Guidelines on Menopause, then Chair Clinical Practice Guidelines on Postmenopausal Osteoporosis, past President Indian Menopause Society, Founder Chair Research Committee IMS, and Founder Patron Hyderabad Menopause Society. Welcome, madam, for such an important lecture. And I think I should not I should not tell much about the lecture because madam is the expert and stalwart in this particular subject. So I think everybody knows that calcium supplementation is really needed to maintain the bone health. So madam, over to you, please.
Thank you. Thank you so much for all the kind words and the, love and affection which each one of you have showered on me. And I really appreciate it and feel very much obliged. And I feel, a little more, I think I'm a little tense now. I hope that I can send across some good message in this particular talk. And I would like to, of course, say hello to all my colleagues. Thank Asha for inviting me. All my colleagues from IMS, Foxy. And actually, we are just sister organizations. All of us work for the same cause of women. So coming to this topic, bone health and calcium supplementation in postmenopausal women, which is a little different from your mainstream topic today, that is MHT. But though it's very simple, it is very complicated. It sounds very, very simple when you look at calcium, but the calcium metabolism and whether it is needed, not needed, it is quite complex. So I have no disclosures. And so I thought first I would, just give a little bit a roundup on what is bone health and then a little bit on calcium and then what is calcium supplementation. So this is one of the pictures which I had taken, you can see over here, maybe long back in 2014. So it's almost like 11 years ago. But this is one of my favorite pictures because this, I captured the little fetus holding the umbilical cord. And so all the NICD diseases, everything actually start in utero. And 10 years later, this year, I have captured another picture, which is, sometimes you just capture pictures which are so rare and which really touch you, like this one. And then I have another one. This was this year. Last December. Now, this lady came to me in the mid-trimester. She's 29, 30 weeks at that time. And when we were doing the scan, the femoral length, when I was doing the femoral length, can you make out something which is very different? I'm sure all of you must be doing these scans, fetal scans as well. Do you think this bone is,
it's bowed. The bone is bowed.
Yeah. So
there's
what
a
you think?
curvature. It's not straight.
It's
and
not
there's no
straight.
shadow behind it.
Correct. So I was wondering really what is wrong with this. And when we did the vitamin D levels, it was like 3 nanograms per ml for this particular woman. So see what we were able to pick up even in utero. And now, we're planning to get the vitamin D levels after the birth. So we know that bone accrual starts off not only at birth, it starts right from in utero. And then it enmasses the nutrition that the mother has. So it's very, very vital as a gynecologist and obstetrician. I would say obstetrician and gynecologist to start looking at a woman right at the preconception so that they give birth to these healthy babies. And then, it goes on like that at different life stages. And it's not just about menopause when you're talking about calcium. So this is the peak bone mass is very, very important. So we will not go into the detail. Now, I have some interesting pictures here to present because I do my own DEXA machine. And we also do the body composition. The body composition is a very interesting aspect of DEXA. Now, when you look at DEXA, you're thinking only about bone mineral density in postmenopausal osteoporosis, but we do body composition, which gives you the bone health, the fat health, and the muscle health, and the BMR. So with this, you do it at any age. So when you're doing this, you capture a lot of things. And over a period of years, I have learned that I can diagnose vitamin D deficiency without even looking at the vitamin D levels. I can say that this particular woman is going to have dyslipidemia without even looking at the lipid levels. So that is the beauty of this body composition. So when you look at this particular picture, and you see this girl, her birth date is 2008, which you can see on the left side, birth date 2008. So she's about 15-year-old. Now this 15-year-old's body BMD, this is showing BMD on the left side and the Z scores and the age in years. So she's 15 years old and you see where that marker is so low. And when you look at the bones, all of them are actually falling. They're so miserable. Can you see the numbers over there? 0.03, it has to be around 1. So this was a case, and she was not able to walk. The parents were very worried because she was not able to get up. She was not able to walk. So it was a severe case of calcium and vitamin D deficiency. Now, when you're looking at this 54-year-old woman, she is, when you look at this picture, the BMD and the age in years, she's 54. Though it is falling into the normal zone according to the T-score, but you look at the arms, when you do the regional analysis and you look at the arms, it is 0.56. When you look at the ribs, it is 0.783. But when you look at the spine and the legs, it is pretty good. That means it is not osteoporosis, but probably it is osteomalacia because the deficiency changes in the bone mineral density occur first in the sternum, as we know, and the shin. So these are the places, the trabecular bones, which get affected first. So this is how the body composition helps you understand the deficiency. But here I thought, when we are talking about menopause, we always talk about osteoporosis. But is it always osteoporosis? No, many a times, because when you do the vitamin D levels, we know the vitamin D levels are so low in India. So probably we are dealing more with osteomalacia than osteoporosis per se, because when you look into the studies and when you see the prevalence of osteoporosis versus the fractures, compared to the Caucasian population, though our osteoporosis is more, the fracture rates are comparatively not as bad as in the Western countries. So probably we're dealing more with osteomalacia, where the BMDs cannot really differentiate when you're doing the bone mineral density. So osteomalacia is very, very important because there is a difference. When you say osteomalacia and osteoporosis, osteomalacia is a defective mineralization of the skeleton, whereas in osteoporosis, the mineral content, the calcium to phosphorus ratio, the collagen and everything is normal. What is happening is the bone mineral density per se, per gram square centimeter is reducing. So that is osteoporosis. But osteomalacia is where the mineralization is defective. And when it occurs in children, we call it rickets. But when it happens in adults, we call it osteomalacia. And this is what I thought I want I want you all to pay attention to. And this is what even in the adults, the X-rays in severe forms can have this. And we are not surprised because it is prevalent in India. And it may be asymptomatic, but generally osteomalacia is not asymptomatic because bone pain, muscle weakness is very, very common. You cannot get up from your chair. Walking and waddling gait is very prominent. Muscle spasms and all the calcium deficiency symptoms can also be present. And like I've shown you, some kind of those fractures can happen in the trabecular areas like the ribs and the vertebra. So this is all about the osteomalacia. But when it comes to osteoporosis, we know it's not all about only calcium, vitamin D, or protein. When you talk about osteoporosis, it is a multifactorial disease where it is the genetic factors, where it is the endocrine factors, where there are pharmacological treatments and so many other things which are involved. So naturally, when you're looking at the treatment, when you're looking at the studies which have shown that calcium supplementation and vitamin D supplementation on its own or in combination, different doses, none of them actually prevent the fractures. So not surprising, isn't it? Because osteoporosis is multifactorial. It is not a disease which is caused only by calcium and vitamin D deficiency. It is aggravated by that because you're not giving the raw material. So unless the raw material is there for the bone to build up, then only the bone can be built up. But the causes of osteoporosis are much more wider than only a nutritional deficiency. So this is very important to understand when looking at the calcium and vitamin D supplementation when you're treating osteoporosis. Now, we have a high prevalence of osteoporosis in our studies, but when it comes to fracture rates, like I said, it is much lesser, and perhaps because we are dealing more with osteomalacia. So how do you differentiate between the two? Osteoporosis, generally, when you measure, the serum calcium levels are generally normal, phosphate levels are normal. Alkaline phosphatase may be increased in very severe osteoporosis where the bone turnover is very, very high. But and vitamin D levels may be low because they can be a secondary elevations of PTH, but they are generally never, very, very rarely below 10 in people with osteoporosis, except for severe osteoporosis where osteomalacia also, the deficiencies are also there, which is adding to the osteoporosis. Whereas in osteomalacia, the diagnosis is very, very, very clear over here because osteomalacia, the vitamin D levels have to be less than 15 nanogram in 100% of the cases. The PTH is definitely elevated. So this is a very important point, that PTH is elevated in 100% of the cases. Alkaline phosphatase is elevated in 95 to 100% of the cases. Urinary calcium can be low in 87%, whereas serum calcium and phosphorus may or may not be reduced. And so this is how you differentiate between the two, because reduced BMD, by doing just a BMD, you cannot differentiate osteoporosis from osteomalacia. So, and the caution is when you're treating these patients based on BMD, which you would think that they're only osteoporotic, you have to do a calcium, you have to do a vitamin D, you have to do a PTH, you have to do an alkaline phosphatase, you have to do a urine creatinine ratio or urine calcium levels before you put them on any anti-osteoporotic medicines. This is a very important take-home point, because if you're going to start treatment for osteoporosis without checking these baseline values to rule out osteomalacia, you're going to do more harm than good, because this increases the bone loss and the patient can come in hypocalcemia. We have had some cases, where the clinicians have given zoledronic acid, and after some time they come with severe hypocalcemic tetany. So we need to be very, very careful. They have to be calcium and vitamin D replete before you start them on therapy. It is okay even you have to wait for a month Supposing the vitamin D comes low, then you wait for a month, get that vitamin D, get that calcium corrected, and then only start the treatment. So osteomalacia related to vitamin D deficiency, of course, is easily corrected, and it may take a longer time, but it is corrected. So now, on a very lighter note, I'm going to now, finish with the bone health in general, and we come to the calcium. What does the calcium say? Now, each specialist will have different way of looking at calcium. The nutritionist will say it's all about the diet. You get the calcium from the diet. The endocrinologist will say, yeah, I know a lot about it because, I said it's very complex to understand the endocrinology of calcium. Whereas the radiologist will say, I love calcium because it gives me a clue where what things are happening. And the gynecologists will say, yes, I found it in the dermoid and endometrium, but I don't like it in the placenta. But the cake is taken by the big pharma who make big money because we give so much of calcium supplementation whether needed or not. So this is where we really need to take care and not advise supplement at any age group. We have to be very, very careful about our calcium prescriptions as supplements. So we know that, so I think I'll skip some of these slides because they are all about how calcium really is maintained, because it has got a tight plasma concentrations. 0.1% is in the blood levels, and that is maintained very well by various hormones. And the role that calcium plays here today, because we are talking about bone health, it partners with vitamin D for bone health, and of course it also needs the other things, that is the protein, the magnesium, the boron, the vitamin K2, and all of them, which are important to maintain the integrity of the bone. But as of anything, the right RDA. So no health is obtained when it is deficient or when it is in excess. So you need to have the optimal levels. But what is the optimum level is the million-dollar question when it comes to calcium and vitamin D. Both of them. So when it is in excess, we know it causes diseases, and we know when it is in deficiency, it causes all of these, which I've talked about. Now, the diagnosis of calcium deficiency is very difficult, because even if you're going to check the ionized calcium, you may really not understand unless she comes in a tetany and you have very low calcium levels. So instead of focusing on the blood test alone, we have to take a good dietary history, and that becomes a cornerstone for us. And of course, it is backed by all the tests that I've told you to understand whether it is osteomalacia or osteoporosis. Now, calcium is very well balanced in the body, the intake and the output, and the bone density and formation that maintains your body, the skeletal form. So they are all, this hemostasis actually can be divided into 4 areas where the calcium hemostasis is maintained depending upon the life stage that the woman is going through, and the load, the calcium load that you're putting in, that is the amount of dietary calcium you're taking or the supplement you're taking. And there are various adaptive mechanisms at the intestinal level, at the cellular level, which is called the calcium hemostasis or the calcium stasis at the intestinal level, which actually, it's like the autocrine organ where it self-regulates the vitamin D levels also. Even if your vitamin D levels are low, the calcium absorption can still be maintained. And of course, you have the presence of enhancers and inhibitors at the intestine and also at the urine where there is an excretion. So all of them, that is why it is so complex and how it is maintained. So I've just put up all these pictures to say that maximum absorption, 80%, is seen during pregnancy and lactation. So you see, nature is so wonderful. During pregnancy and lactation, where the calcium needs are increased, the same amount of dietary calcium which any of these women are taking in their lifespan, but the absorption increased. So by default, the calcium and the vitamin D levels are maintained. So similarly, as one is aging, at the menopause transition, a small child and the older woman, the absorption decreases for various reasons, and estrogen being one of the major factors which causes a decrease in the calcium absorption. There is an increase in PTH and causes the brittle bone. So the overall demand for dietary calcium is greater in postmenopausal women, and that is why the RDA increases. But having said that, I said even if some amount of calcium is taken from from your diet, the adaptive mechanism is such that if you're taking 500 milligrams versus 700 milligrams, somebody has low calcium levels, even with the 500 milligrams, the vitamin D will work much better. It's just, this analogy is similar to your iron. We know when there is iron deficiency anemia, you're giving them the iron, you know, the response would be much higher than people who have got, say, very good iron levels. The people who are not anemic, you give them iron, the levels may not increase as much, but the people who are anemic, when you give them the iron, the levels increase very well, the response would be very good. So the similar analogy to calcium. So these are all the calcium absorption and decreased calcium absorption, various states which are easy to pick up. Also, how different mechanisms alter excretion. And we know thiazide diuretics used to be one of the factors which we say people who are on them, along with osteoporosis, that would help build up the bone. And now, so so nature's adaptation system, it protects calcium balance against low calcium intake. But very, very interesting is the fractional calcium absorption. I will not go into the details, but this is a very interesting slide because the calcium isotope studies are very, very difficult to do. In China, when they did this, they found that the absorption is higher even at 500 milligrams compared to the children in US, where there is high calcium intake of 900 milligrams. So we can adapt this to the Indian situation. So even if there is less than 500 milligrams, the absorption would be higher, that is 60 to 80% versus 40% when the dietary intake is 500 milligrams. So this gives you an idea as to why the RDA difference is different in different countries. And this is a very, very interesting slide, which from the WHI, the African Americans have lower fracture rates, higher bone density, and lower vitamin D levels generally. But in spite of that, they don't fracture the bones because there's skeletal resistance to PTH. So the PTH doesn't, clear up the bones and make it brittle. Whereas in the WHI, what they found, the higher fracture rate when the vitamin D levels were higher. So it works when it is in excess, it works the other way around. So the racial difference, the end organ problems are all there. So the racial differences, the microbes in the intestine, the absorption, all of them play a role when you're looking at the RDA. And calcium deficiency is worldwide, except in the well-developed countries. You see the dark green, India falls in them. The dark green is the one which is deficient. And this is from the recent study from the NHS, the NFHS from India, where you can see the amount of calcium that is taken is 200 to maximum is 500 in the urban and the rural areas. So it is much, much less than the ICMR recommendation. Just now I'm going to talk about that. So the calcium intake is generally less than 400, between 200 to 300. Low vitamin D levels, this was a study I was involved in. 80% of the health professionals had low vitamin D levels, low protein, sedentary lifestyle, and early age of menopause. And why? There are so many reasons. But the good news is it's correctable. That means a lot of things can be done to correctable. These are all modifiable. The World Health Organization says 1,300 milligrams per day for adults, whereas Asian countries recommend 800 to 1,000. There is a lot of difference. The Indian Menopause Society, we say 800 milligrams because of so much of data which we have collected on, and the RDA, which we would want our women, postmenopausal women, is equal to or more than 800 milligrams up to 1,500 to 1,000 milligrams. Whereas the ICR has suddenly changed its stand. In 2021-22, they have increased the dose to 1,200 milligrams. And this is 1.5 times higher than the earlier group from ICMR. So that is why we are not concurrent with them, because this becomes too high a dose for Indian population, and that would push people to give more and more supplement, which is not really right. So there is no test. So first thing is ask. Very simple question. How much of milk do you take? How much of curds you take? How much of lassi you take? From the non-dairy sources, you get 300 by default if you're taking a normal diet. And it's very easily to calculate the amount of calcium that can be done. Now, the calcium paradox is at postmenopause, the calcium from the bones is taken. Again, I have this very old picture of 1998 of an old woman, and you see the ring of calcification around the uterus. So I used to wonder why all the calcium goes in deposits in the vessels and all that is taken off from the bone. And this is the calcium paradox. So, but can this be reversed? And if it is to be reversed, whether it is a diet or supplement, dairy products are always the best. So I know very good calculation is 3 cups would give you 1,200. 1 cup of milk is about 200. So, but there are various reasons why you're not taking from the diet. So is there a rationale to supplement postmenopausal women with calcium and vitamin D? Yes, whenever the patient is osteoporotic, whenever they're not able to take it from the diet, whenever you're giving them, or they have some diseases where the calcium is a problem, or the vegans who have totally given up the milk. I think these are the places where you need to give. I have put it very simply. When there is so the target intervention, it is not supplement for all. It is supplement only when there is an inadequate dietary calcium, when there is a risk of osteoporosis or the woman is on osteoporosis, elderly, institutionalized women. Elderly does not necessarily mean people who are active, out in the sun, having a normal diet, no osteoporosis, really healthy, just a little bit of low bone mass, they may or may not need it. Pregnancy, of course, we know that we need to supplement. So there is a huge gap even in the guidelines because we talk about supplement, but we don't talk enough about the dietary calcium. And this is from one of the systemic analysis of all the guidelines available. And this is what was said over there. Because definitely the advantages of a dietary calcium is much more compared to the supplements that you're taking. And there is enough which you can take from the summary of our recommendations. We have enough of the Indian food, ragi, chana dal, rajma, you have your chole, you have the milk. People who don't take milk can also take it from all the other substances that we have in India, easily available. So we have to promote them. Now, types of calcium supplements, we know in our everyday practice, it is carbonate, citrate, gluconate, lactate, everything. But the percentage of elemental calcium, which we get out of 1,000 milligrams of 400 milligrams out of the 400, out of 1,000 is only 400. So you have to be very, very careful, very, very choosy about the combinations. Please don't prescribe calcitriol. Most of the combinations that we have is a calcium carbonate or a calcium citrate. Nowadays, we have the vitamin D. When you have the vitamin D, check that it is only it is not calcitriol. It is not the active form of vitamin D. It is the 25-hydroxy vitamin D, which is pretty safe, whereas calcitriol, after some time, can be bone resorption rather than bone forming. So we have to be monitored very closely if you're prescribing calcitriol, which is reserved for women, for people with renal problems, and they have to be monitored. So calcium carbonate versus calcium citrate, yes, both have their own advantages and disadvantages. The citrate is a little more expensive, but probably more patient friendly. So that is how the difference is. And so limit always, whenever you're giving the calcium dose, don't go for those capsules which say we have got, we are giving 1,200 or 1,500 of the calcium, and you're getting almost like 750 of elemental calcium out of this. Please don't go for those kind of preparations. Pick up a preparation which gives you less than 500 milligrams of elemental calcium, because that is how the body will absorb that much at one given point of time. Beyond that, the body doesn't absorb, it all goes waste. So don't go for that, and always space it up. Best is space up the calcium, and you can also start gradually and increase step up the dose if you feel the woman has a little gas and constipation. So always caution whenever a woman is on thyroid, corticosteroids, tetracyclines, anticonvulsants, give it separately. Contraindicated, of course, in patients with hypercalcemia, renal insufficiencies, and cardiovascular disease. There is no contraindication as long as you restrict the calcium to less than 2,000 milligrams. So that is the take-home point. And vitamin D is necessary for your calcium absorption. Remember that, but remember the kind of vitamin D you're going to give for this woman. And the guidelines from India is the total calcium intake from dietary sources. And if needed, supplement is used for deficient balance. The intake should exceed 800 milligrams. So I repeat again, go for whenever you need to supplement also, you have to talk to the woman. At least the 50% has to come from the diet and 50% from the supplement. You're not going to give only the supplement and not talk about the diet, then you're not doing good service to your woman. And the risk of cardiovascular events are not there with this. So the guidelines say consume about, say, half a liter of milk if possible. If not, at least 1/4 liter of milk supported with a lot of vitamin C, protein 1 gram per kg. Restrict the caffeine, restrict the salt, limit alcohol, and be careful about the medications and diseases which have an effect on the bone health. And this would be a very simple way of giving your calcium and vitamin D. So why are we talking about bone health? We are gynecologists. We look at the uterus. Yes, but then like I showed you the first picture. Our role starts in utero, in adolescent, attainment of peak bone mass during puberty and later on at menopause. So, I thought I'll just put up this final slide, fit at 40, strong at 60 and independent at 80. Thank you so much for giving me this opportunity to speak on this topic.
Thank you very much, ma'am. Such a wonderful lecture. ऐसा लगता है सुनते ही रहें. I should invite our chairpersons and Dr. Archana Sharma ma'am and Dr. Ritu Devkota sir for the concluding remarks.
Shishma, before I'm extremely sorry. You should have stopped me. I didn't even realize the time. I'm so sorry, Asha. I took up so much of
I
time.
think we are all
actually, see, we are here to learn. My whole problem is that the audience runs away if it is too late.
I know. I'm
That's
so
all.
sorry.
So-
I feel terrible
No,
when I
but
go
it
beyond
was-
the
it was-
point, but I
it
didn't
was
realize
great.
it.
It was
And
great.
none of y'all gave me a hint that I need to stop. I'm so sorry.
No, ma'am. It was wonderful lecture. I think everyone was hearing एकदम ध्यान से सुन रहे थे.
Yeah. Let's start the panel. Thank you.
So, Archana ma'am, would you like to say something?
No, nothing. It was an excellent lecture. It has given so much learnings to us, so much things we have learned from these two lectures. Rather, Dr. Shobha's lecture was very good. So you can continue as we are running short of time also.
Yes.
So, my request to all the chairpersons here, you are not officially my panelists, but I request all of you to pitch in and answer the questions, because whenever a topic is tough, the panelists tend to drop off. So as usual, a lot of panelists have not joined in. So anyone is open to answer, because these are just situations. Shobhadi touched upon them and said that we'll discuss in panel. So anyone has an answer can pitch in and answer. You're all welcome. So that's me. And our expert today is Sadhna Gupta ma'am. We all know her. She is Sadhna Di. She is Foxy past chairperson, Safe Motherhood Committee, ICOG Governing Council member, ISOPAB, Executive Board member,
Asha,
and everything.
Thanks for the invite.
I don't think there's anybody who doesn't know you, ma'am. There's Dr. Priyanka Rai. She's an associate professor and faculty in charge, AIMS, Devghar. She is traveling, but she has joined in. I said, you joined from the mobile, so she has joined in. And these
Hello,
are our
everyone.
panelists.
Good evening.
Good evening. If you could just, yeah, you're unmuted. So that's fine. Requesting all my panelists, please put on your camera if possible, and you can unmute yourself. So the invitees were Dr. Vijay Kumar, Secretary Davangere, Dr. Chanchal Gupta, she's here from Secretary Faridabad Society, Dr. Shruti Patil, President Gadag, Dr. Annapurna Dhanur, Secretary Gadag, Dr. Manisha Jain Agarwal, Secretary Ghaziabad, Dr. Babita Shukla, VP Gorakhpur, Dr. Sadhna Jaiswal, President Greater Noida Society, Dr. Samta Gupta, Greater Noida, Secretary Greater Noida Society, Alpesh Patel sir is here, who's the Secretary of Godhra Society, and Dr. Alpana Agrawal, Senior Gynecologist from Bareilly. She was very eager to join in. I don't know why. Yeah, madam has joined in. So welcome all my respected panelists. And we would really be having a... So this is, I officially seek all your blessings in the form of nomination for Food, Drug and Medico Surgical Equipment Committee, FOXY. Nominations will come to you in May. I request all of you to get me nominated from your society.
Yeah.
So we have one case. This is Mrs. S, 55-year-old postmenopausal woman. She presents with a history of early menopause at 45 years. She has a family history of osteoporosis, with her mother experiencing multiple fragility fractures in her 60s. She leads a sedentary lifestyle and consumes diet low in calcium and vitamin D. So, what are the risk factors in this case? Dr. Chanchal?
Yeah. Ma'am, in this case, the risk factors are she's been menopausal, slightly early menopause, that is at the age of 45. And she has a family history of osteoporosis. She leads I mean, almost all kind of risk factors she has. She leads a sedentary lifestyle. She has decreased intake in her diet of calcium and vitamin D3.
Okay, so what screening test are you going to do for her bones?
Ma'am, the screening test in this case I would like to do is one is the most important thing, as in the previous lectures also Dr. Geeta and Dr. Shobha had told me the most important is doing a history taking, which will give us an idea regarding her diet, what she's taking, her lifestyle, how she is, and obviously, as in this case, the family history also. So history taking, then the examination is involved. Examination tells us about her bone health in the form. Does she have any postural problems? Her muscular, her BMI, all those status can be seen from
Ma'am,
the.
I'm talking about tests. Which test would you advise?
Ma'am, I would like to advise her the blood test, which include her serum, her CBC, serum calcium levels, vitamin D3 levels, parathyroid hormones, and BMD.
Sadhna Didi, would you like to add something here?
In this, actually, the two things are there. It is the early menopause and then the family history of osteoporosis. So a few things about it. Meeta has already said that how we should differentiate, but in what clinical practice, what we really do, that is what hemoglobin total blood count, serum vitamin 25 OHD level. At the, like in my practice now, we are doing a vitamin B12 as well and the DEXA. So this is the thing which we offer, and of course, thyroid screening and that screening for the diabetes. And so this is what we are doing into the common clinical practice. Routinely, we are not doing parathyroid hormone and serum calcium level and the phosphorus. Actually, it does not correlate so well with the actual. So DEXA is very important, and if we find DEXA is osteopenia, osteoporosis, what is the grade? And then we will go ahead. So these are 2 or 3 things which we do in our clinical practice.
I think we need to add alkaline phosphatase as well.
Yes, alkaline phosphatase. Yes.
Alkaline phosphatase is what we were looking for. So do you think there will be any benefit of HRT in this case?
Yes, ma'am.
She is 55 years old. Do you think there will be a benefit?
Dr. Asha, can I just
yes, ma'am?
make a point? This is a very important point, I think, for screening test, When you're talking about screening test would be different from diagnostic tests like DEXA, So
Yes.
did you have anything else in mind, Asha, when you put that screening test? Or are you happy with
that? Would you
that?
suggest? No, you go ahead. We are eager to listen to you.
No, with you. Because see, actually, when you say screening, then you're doing something which is not diagnostic, but you're kind of screening the entire population. So we promote the use of OSTA, which is a very simple test, or the FRAX. The FRAX with or without BMD. Like many people may not have access to the bone mineral density by the DEXA. By doing the other substandard tests for DEXA, the ultrasound based and all of them will not give you a true picture. So when you're saying screening is that. So once you screen and you're highly suspicious, the FRAX gives you, these are very simple algorithms by which you screen and you say these are high risk for, by the questionnaires, by the history. And then you go on for DEXA. Yeah.
Thank you, ma'am. Ma'am, I would request you to share that FRAX questionnaire in the group.
Sometimes they go for serum calcium level. Is it really important or useful for the
that would not be a screening test. So is there any advantage of having hormonal therapy for this patient?
She is less than 60 years with risk factors. So I would like to start her on hormonal replacement therapy, ma'am.
HRT is mandatory for this type of cases, ma'am.
Yes.
Okay. how are you going to counsel her about her lifestyle?
Ma'am, as she's having a sedentary lifestyle, definitely
Ma'am,
there is a
ma'am, I would like to add something that
Yes.
for hormonal replacement therapy, there is a risk of osteoporosis in this type of patients, and nowadays it is recommended combination therapies. Means calcium with bisphosphonate or tibolone or with HRT or with parathyroid hormone. So
Ma'am, we
nowadays,
are coming to that. Dr. Priyanka, we are coming to that. We are
okay, ma'am.
coming to that. Okay.
Hmm.
So now, how are you going to counsel her about her lifestyle?
Ma'am, she has to be more physically active. That is, she needs to, that definitely helps in binding the muscles, and obviously the postural stability is better in such cases. So she has to be like we recommend dancing or whatever kind of brisk walking she can do at least 15 to 20 minutes per day. Then she needs to have replace lifestyle. She needs to take more of calcium and vitamin D intake in her diet.
No,
That's
we'll
it.
come. Right now, we are talking just to the lifestyle.
Right.
Then we come to the pharmacological interventions. What are you going to do so that she doesn't get the fracture? What are you going to add? So Dr. Priyanka has said you're going to give bisphosphonates.
Bisphosphonates.
And you're going to give calcium and you're going
Yes,
to
ma'am.
give hormone. Anybody wants to differ or add
Actually,
something?
what we say, any study on the bone health with a brilliant talk by Dr. Meeta, no study can omit the calcium and vitamin D3. So this is one of the basic thing, be it a bisphosphonate, be it a hormone replacement therapy, because it will be against ethics. So one thing very important, no study in the world in the bone health can omit the calcium and vitamin D, be it from the diet, be it from the supplementation. But this is very important. And when we say the initiating hormone replacement therapy, so always there is a comprehensive assessment. Actually, hormone replacement therapy can never be the prescription that we can write or like just we write, because it what is her weight, what has been the her risk factor for the other cancers, endometrial, and some everything about it, whether she is able to have the follow it, she wants it or not want it, and what are the benefits and what are the risk associated. So hormonal replacement therapy, be it any situation, be it a calcium or this bone health, be it anything, it can never be a prescription that we just write like a something be complex. Though Meeta have said really cautioned about the going very discriminate about calcium prescription, but hormone replacement therapy is something very important issue, and the always the overall clinical profile, the socio-economic, all the scenario surrounding the woman, and what are the risk factor for everything, be it a bone health or be it the other issue. So this is something which practice in the day-to-day clinical life.
Basically, what I feel, Sadhana ma'am, is gynecologists themselves are a bit scared to start with the hormonal replacement therapy.
See, that is why we are having this session, Dr. Chanchal. So now what my question is, she has started HRT, she is taking vitamin D, calcium. Now, how often are you going to monitor her bone health? She has started HRT. When are you next going to monitor her? Yes, Dr. Priyanka.
One thing that she is having a history of sedentary lifestyle and consumes low diet calcium and vitamin D. So first we have to rule out any sort of risk factor is there or not before starting HRT.
No, that is done, ma'am. See, we are taking different aspects. In every case, we are taking different aspects, and I want everybody to focus only on those general aspects, because basic things have been, yes.
Yeah,
yes.
Asha, Shobha here. Shobha,
yes,
yeah.
Didi.
So Asha, So in this case, I think she will benefit immensely with menopause hormone therapy structured to her needs for at least 3 to 5 years till she reaches the age of 60. It will give her
The
better
question
protection.
is, how are you going to monitor her bone health?
Monitoring. So monitoring is, yeah, correct. So monitoring for NCDs and for other risk factors and
no, ma'am, I'm just talking about her bone health.
Yeah.
You here the question is related to bone health. How are you going to monitor her bone health?
Ma'am, by BMD,
yeah, actually once we start for bone health, once it is already identified that there is, it's actually not so important to frequently do DEXA. It is not so
when
important.
Will we
there
do
are
it?
some
when will we
bone,
repeat it?
maybe once in a year to make sure, but I don't think that there is any relationship between, giving an MHT and improvement in BMD. It doesn't happen like that. Your intention is only to prevent further bone loss and to prevent fracture, and along with other fracture risk reducing strategies, because that is also important. And as Sadhna ma'am so clearly said, Sadhna ji said, and Dr. Meeta also said, calcium, diet, and somebody pointed out lifestyle. So this has to be a very multi-pronged approach. And in this patient,
I'm just saying, I'm the patient, I'm
bone
eating
loss.
your head.
Yeah.
I'm eating your head. How will I know that it is improved? So, ma'am, you got
it will improve by no further worsening. It will improve by no further worsening. I think Meeta will agree with that. What do you say, Dr. Meeta?
We can say, Asha, actually it is a monitoring once a year is okay, but important thing is patient herself says, my backache, my bone pains, I am feeling good, I am feeling active. So
there will be improvement.
Always the patient.
So it will be a subjective improvement.
Yes.
Clinical subjective improvement.
It is more clinical. Yes. Not any test. Test is not needed. Yeah.
Ma'am, it is clinical improvement, and for DEXA scan, it has to be repeated after 2 years.
Okay. Thank you, Dr. Babita, for that. So now we go to the next case that, each case has a certain subtle message. Let us focus only on that because we agree on the generalities that have been covered in the lectures. So Ms. J is 60 years old, postmenopausal. She had bilateral oophorectomy at 50 years due to ovarian cancer. She is on aromatase inhibitors as part of her adjuvant therapy. Now she complains joint pain, stiffness, fragility, fracture of her wrist after a minor fall. What do you think is the cause in this case? What caused this fragility fracture? Anyone can take it?
Ma'am,
maybe due to osteoporosis?
Fragility fracture will be because of osteoporosis. So how would you assess her bone health considering history of oophorectomy and now she's on aromatase inhibitors? She's on letrozole at the present moment. And how are you going to assess her bone health?
Actually, as aromatase inhibitors, ma'am, they definitely cause loss of bone density, and there is an increased risk of osteoporosis and bone fractures. So she has to be again assessed on the basis of DEXA scan, that is bone densitometry.
So what are the challenges in managing her bone health? What are the challenges? How are you going to manage her bone health? You cannot stop her aromatase inhibitors. So Dr. Priyanka, Sadhna Didi.
Actually, this is the situation. First of all, I will not go for any HRT because she is a ovarian cancer. As far as my personal opinion, maybe many like menopause expert may be liking, but if there is a history of cancer, then I will not go for this thing. Secondly, we have to give all the things which have been said. It is a good lifestyle. It is a good calcium and vitamin D3 diet and a good monitoring and making her about confident. And actually in these situations, what I say, it is a multidisciplinary. It is because we can have the bone metastasis as well. It is, we are thinking only for the bone health, but any bone pain and something, maybe something telling about there is any bone metastasis or something. So like, I will need to have the consultation with the orthopedic person as well as the people who are treating for her cancer. So all the decision, it is difficult for us to take it.
Okay,
and
so
it is not
now
only
she does not have any bone myths. Anyone would consider offering her yogasan karo, pavan muktasan karo. Do you think
that to sabhi ke liye hai, sabhi, it is for everybody actually. It is for, if they have a good teacher like you. Yoga is something which is we talk about so much, and it has been a little form of commercialized. But
no, ma'am.
Anyway,
Pavan muktasan. If somebody is able to do pavan muktasan,
that is, I say, they must have the good teacher. Actually, they must have a good teacher. Otherwise, all the brisk walking and everything is okay. Dancing अभी किसी ने कहा, और I am a little bit concerned क्योंकि अगर किसी ने इस उम्र पे डांस करना शुरू किया, they are more liable to get falls and more liable to have the fall and fractures. So somebody told, so world is not like something what we see in social media. World is very, very different about it. And in malignancies or something, we need like we have to have the opinion of orthopedic people as well as the people of
we can add phytoestrogens in these patients. We can add selective estrogen receptor modulators in few patients which are not hormone dependent.
Agreed. Yes, so we have to look for other ways.
आइसोफ्लेविन्स के बारे में बहुत बात होती है, लेकिन जहां हम 10-15 साल में मेरे ख्याल से हम लोग उसी पॉइंट पे आ गए हैं, and if they are, how they are beneficial actually in real term, we don't know. It may be having some add-on benefit on overall health, but how far it is beneficial for particular such type of situation, actually research are not consistent at all.
Ma'am, I actually read one paper, and that said that isoflavones are active, phytoestrogens are active in plants. The tragedy is we are not plants. So
yes. Because studies are actually inconsistent. A lot of things, a lot of preparation. We take it because medicine is looking for the nutritional options. Be it PCOS, for everything. What is in nutrition, not medicine, is good for us. So it's okay to have. But actually, it is really solving certain problem like a osteoporosis or something. We have a good question mark about it.
Ma'am,
so now we come to the next case. Yes.
SERMs, ma'am, selective estrogen receptor modulators can help.
Yes.
Along with bisphosphonates and teriparatide, we can add. In this patient, we can add bisphosphonates, teriparatide, etc.
Agreed.
So now this point is a patient
to say one thing, that bisphosphonate, Babita is also, her husband is orthopedic person. As a OB-GYN, because they have got a very strict dosage schedule, a good number of side effects, a good monitoring as a OB-GYN, and all legal issues, always considering all the things. Do we not need to have the orthopedician in our loop, and we can prescribe like bisphosphonate on our own for a long term, because it is not that the drug, it has got its own effect and we have to be careful. So just a question, what you are practicing? I am a little scared about it.
Ma'am, involving ma'am, we should always take help of, it should always be a multidisciplinary approach. Yes, and we should always,
thank you,
because when you give long term, when it is given for a long time, then it causes GI upset, it causes reflux esophagitis, and those patients who are unable to sit for stand for 30 minutes after taking bisphosphonate, the chances of side effects are also more. And when we give them for a very long time, sometimes they cause brittle bones, and there could be jaw necrosis, especially the mandible during dental extractions.
Dr.
So
Babita, see, we have a guideline that you do not give them for more than 2 years at a stretch.
Yes, ma'am.
So you have to give them for 2 years, and then you have to give a 6-month break for that.
Yes, ma'am.
It's okay, but Babita, thank you very much for
involve
it.
orthopedician, then legally we become safe. We can also
that is fine. That is fine.
Just
That
for the
is
legality
fine.
point.
So now, this is a case of rheumatoid arthritis since the age of 40 years. She's 55 now. She's been on steroids for the last 15 years. Now she has progressive back pain and loss of height. So how do steroids affect bone health?
Steroid is the most common cause of osteoporosis.
Okay.
It
So
mainly
what is
affects
the
madam, it mainly affects the spinal, I mean the vertebral column. So there is
loss of height.
fractures and there is loss of height.
Okay. So now she has, what are the challenges in diagnosing her osteoporosis? Are there any challenges or is it easy in the diagnosis?
Rheumatoid arthritis itself causes some changes, and but if we do a DEXA scan, we'll definitely get low scores, and even if we do an X-ray also, then we can see the compression fractures in these patients.
So my basic question: are you going to give her HRT or not?
Ma'am, we will keep her on biphosphonates and calcium supplementation and vitamin D. That should be the first choice. But with
HRT, yes or
orthopedician
no?
opinion, because there is also associated rheumatoid arthritis.
She is already being seen by an orthopedician for her rheumatoid arthritis.
Yes,
She's
ma'am.
under regular touch of that person. When she comes to us, my question is, are you going to give her HRT, yes or no?
Rheumatoid arthritis is the area where HRT can be beneficial, and we can, at this moment, like we should intervene in the field of orthopedic, that she is having arthritis and HRT is supposed to benefit this particular condition, and it is something we can, if she is not well on the what is the conventional treatment, that is the time that we should give the HRT for around 6 to 9 months at least, and see how it is effective. So we are interfering in the orthopedic thing because the HRTs has been shown to have the beneficial effect on the progress of rheumatoid arthritis as well. So this is my, and we look forward to others' opinion on this.
Ma'am, now we proceed to the next case, because see, each case has one take-home
One
message.
doubt,
That's it.
should we continue the glucocorticoids along with it because it is causing damage and again?
We are not interfering with the orthopedician.
Okay. We will just add HRT in this.
We will do what we can. We will talk to the orthopedician, but basically our question is, she has come to us now. The orthopedician said, you go to the gynec and have a consult. So what we are worried about it, are we giving her HRT? Because the orthopedician has already given her bisphosphonate. He has already given her
even other things,
calcium, vitamin D. So she has come to us only for HRT. Are we giving it or not? My brother is an orthopedician. He is in AIMS Raipur. He's the HOD. He prefers to give HRT for 3 to 6 months every year to such women.
Okay, ma'am.
That's his protocol.
I'm a bit concerned about the glucocorticoid because it is causing damage. And
we are not doing anything. We cannot do anything about it. That is for the orthopedician to manage.
Thank you. I'm happy that I am in tune with your brother.
So, ma'am, now we come to the next case. She is 63 years old. She had primary ovarian insufficiency since her early 40s. She's been on HRT since then, 23 years. Now she has been on HRT and still she's presenting with hot flashes and night sweats. She is on HRT and she still has this problem. So what are the potential causes of persistent vasomotor symptoms in spite of HRT?
Some cardiac disease.
Exactly. Has to be ruled out.
Has to be ruled out because already she is taking HRT, and actually we don't have indication to give HRT beyond 60 years, and she is already 63 years old.
Yes.
So we have to see whether she is suffering from some hypertensive disease or some cardiac problem, which may be the reason for the vasomotor symptoms.
If somebody has primary ovarian insufficiency, does that alter her bone health?
Definitely, ma'am.
Yes, ma'am.
For her symptoms, do you want to add anything? You've had a cardiovascular consult and it is normal. So
Yes, ma'am.
now she has that.
Now that she's not responding to our conventional hormone replacement therapy, we should think of adding other drugs like the SSRIs or the SNRIs. And we can also try gabapentin if she is not responding, or also pregabalin.
Okay. So are we thinking of non-hormonal options now? Because she's been on hormones for 23 years.
Yes, ma'am. Definitely.
Yes, ma'am.
So what are you going to counsel her? See, people who have been on hormones for a long time, they mentally are not agreed to stop them. Sadhana Jaiswal, ma'am?
Yes, yes.
What is your counseling going to be on this patient?
We need to tell her that what are the risks of continuing with the hormone therapy after 60 years. And so she has to switch over to this non-hormonal therapy like SSRI. So that is the main thing we need to emphasize. Yeah.
So now we come to the next case again. She is 57-year-old. She has had anorexia nervosa since teenage years. Now she has a BMI of 16 and avoids dairy products due to lactose intolerance. She has presented with stress fractures in her lower limbs after starting a new exercise regimen. So how does anorexia nervosa affect bone health?
So because she's having lactose intolerance also, and she's avoiding dairy product. Anorexia nervosa per se is going to affect her bone health. The bone density will be very less in this case. So she's very prone to get stress fractures. The BMD will be low.
So her risk factor would be basically that she initially had a very low bone mass because she has had anorexia all her life. So how would you assess her bone health? The assessment remains the same. So now she is not taking dairy. So what dietary modifications would you recommend?
So besides milk, she can have things like ragi, and we have in the vegetables which are rich in calcium, like drumsticks, cabbage, and the soya beans. So all this diet modification has to be given to her, which are rich in calcium, diet rich in calcium, besides milk.
And also protein supplementation is important for her.
Yeah, because she has a BMI of 16.
Should also be increased in the diet. Total calories, because she's having very low BMI. So we need to focus on that also. The extra calories need to be given. Yeah.
My question to all of you is, would you want a psychiatric evaluation on her?
Sure, ma'am.
Yes, yes.
If she has not taken by now, it is 16 years.
Yes.
And she is going to have not only the bone health, actually multiple nutritional deficiencies.
That's a good point.
We should do all vitamin B, folic acid, B12, all these levels.
Because she is anorexia nervosa, अभी तो जीवन कट गया उसका. So
अभी कटा नहीं है. अब अकेले होने के बाद सारी समस्या समझ में आ रही है.
Yes.
Yes,
Asha.
Yes, ma'am.
Yeah.
Yes.
That was a very solid point made by Sadhana ji, that if it is not done so fast. But that was very astute. But the fact that a diagnosis of anorexia has been made, I think that she has seen a psychiatrist at that point of time. But right now, she is not presenting with any of psychiatric symptoms. I think it is very, very important. Already she has stress fractures, lower limb, after starting a new exercise regime. So she requires very, very focused care for bone health. And I don't think
what
that
are you going to give her? What are you going to give her?
No,
when she gets a fracture, when she gets a fracture, she's consulting an orthopedician. हड्डी तोड़ के तो वहीं गई
Yeah,
है
but
ना?
she will
Now
be.
they have called you for a
She will be.
consultation. So now what?
Yes.
You're giving
So
her
she
HRT
will
or
be
you're not
on.
giving her HRT?
We'll give an HRT, yes.
So if you want to know about menopause hormone therapy, then yes, already established osteoporosis and stress factors, it is not going to help.
Not good.
It will not help in this case. It will not help. But if you wish
So
to
what
give
will help
her
her?
for
What
other reasons,
is going to help her?
Ma'am,
what
calcium
is
and
going to help
parathyroid
her is
hormone.
And
management.
calcium,
Yes,
vitamin D,
yes.
total nutritional
And
correction.
bisphosphonates also.
Yes, we will add
Bisphosphonates and
bisphosphonates in this treatment.
teriparatide, and very focused treatment by the orthopedician and their team and the physiotherapy team because they need to tell her what kind of exercises to perform in the presence of fractures and how to go about it. So it is going to be very rehabilitative care for this patient, and hormone therapy will have less and less role because she will not be freely ambulant also. So I think she will have higher risk of DVT. So it's important to be very careful about MHT. Give only if there is, but the other treatment is going to be. So gynecologists can do very little here except for screen for cancer, etc. Yeah.
So that is also an important point, that there are certain cases which you should stay away from. So this is 61-year-old postmenopausal. She has COPD, diagnosed 6 years back. She's been taking steroid for exacerbations. Now she has worsening dyspnea and a recent vertebral compression. So this we've already dealt with. Now
Yes,
she
ma'am.
has osteoporosis with COPD. How are you going to manage this? She's 61, she has osteoporosis, and she has COPD. How are you going to manage it?
Here we can.
61. Ma'am, here we will give her bisphosphonates.
Bisphosphonates will be helpful here.
Because 61 years, there's no point in giving menopause hormone therapy. So, I mean, she's a 61-year-old. These patients, they have poor nutrition, they have low BMI, they have a sedentary lifestyle. We will ask them to be more active, change their lifestyle. Then proper nutrition containing proper calcium, vitamin D, exposure to sunlight. And along with that, we will add bisphosphonates.
Okay. So now we go next. 52-year-old postmenopausal woman. She has an intact uterus, presents with severe hot flashes, insomnia, vaginal dryness. She has no significant medical history. So what are the potential benefits and risks of adding HRT here?
Benefits are like she's having so many symptoms, hot flashes, dryness, vaginal dryness, which are actually affecting her quality of life. So these symptoms will be relieved. But when because she has an intact uterus, so when we add HRT, we have to give the continuous combined therapy so that the uterus is protected and endometrium is not affected.
Okay. So are you going to assess a cardiovascular risk? Alpesh sir, you haven't said a word.
Yes, madam. We would like to assess the cardiovascular risk.
Okay, so what test would you do? Just an ECG, or you want her to do a TMT or some blood tests?
Echocardiography.
Ma'am, we can go for a lipid profile by BMI and blood pressure.
Rule of diabetes, 53-year-old, we should do a blood sugar level.
Everything what will be needed to assess the cardiac status, and then only we can start HRT in these
Which
patients.
route of HRT would you give? Transdermal, vaginal, or oral?
In this particular case, ma'am, for the hot flashes and insomnia, we can go for SSRI or SNRI or pregabalin, gabapentin. Or for the vaginal dryness, we can add vaginal estrogen cream.
Yes.
It will be a better option for these patients.
So you're not actually giving her HRT. Sadhana, do you want to say something? You're muted.
Actually, yes. Hot flushes is the thing. Rightly says
She's
it can
only
be
52.
It can be the surrogate marker of cardiovascular disease. So rightly, and hot flushes and the urogenital atrophy. These are actually two real indication where we should consider the hormone replacement therapy, because it definitely improves a great quality of life, which can disturbing her day-to-day life. So this is the real situation that once we evaluate, and I think be it hot flushes or not, every woman over 50 and every man over 50 should be like, what a huge burden of NCD in our country and South Asia. So that has to be in our clinical practice, that you yearly get all these things done. And this is the indication for, and it is, she is having hot flushes, insomnia. So my choice will be the estrogen progesterone. Estrogen,
Yes, ma'am, definitely estrogen progesterone therapy is the
estrogen oral we can give, and we can give the patch as well if they are available. I am using a lot of patch as well. So estrogen progesterone, vaginal dryness, I think if we take orally, it will take care for itself. If it had not been the hot flushes and only vaginal dryness, then we go to for the local vaginal application. But in this case, we will switch to the local, and we will say, let you give, take it for 3 months, see how it is happening, and then after 3 months we will assess what is the frequency, how is going on, and then we will look
yes,
for
ma'am,
that how we
definitely
can.
MHT is indicated. It is the first choice in this type of patient. Only
One
when
thing
the
is,
patient
now the question is, how are you going to monitor her endometrial health? What are you going to suggest?
Every 3 months we will call her for the ultrasound imaging for the TBS, and looking for what is so. And before that we will look for it. And because you have not mentioned what is weight and other thing, and we are ruling about diabetes, because again, if there is a lot of risk factor, diabetes, hypertension, something, so then we have to have the before starting and then after 3 months, what usually we do.
So now in this question, I would like to ask anyone, any woman who has come to you with menopausal syndrome, what are the basic lists of tests that you're going to do for her? You know, just what Sadhana Di has been saying, that you have to assess her overall health. Same thing said by Dr. Shobha Di and also by Dr. Neeta. So what is the basic battery of tests that you're going to advise any woman? It's unrelated to this case, but that is a basic question.
So the basic test will be begin from complete blood count, her blood sugar level, her thyroid profile, lipid profile, and the self-breast examination along with the mammography. And I would also see the transvaginal sonography, what is the status of her endometrium. So these are the basic things we have to.
Okay, anybody wants to add anything to this?
Thyroid, I think, Sadhana, you have taken it. Thyroid and lipid profile. Lipid profile is
Lipid
thing
profile
which
is covered.
we can,
And I would have detailed clinical history.
Densitometry for these patients.
And smear, pap smear, if not done.
Yes, pap
till
smear.
now,
Pap smear,
not
yes,
done.
ma'am.
Now, this is a next case scenario. She's 27-year-old, has premature ovarian failure. This happened at the age of 25. Now she comes with symptoms of estrogen deficiency, including hot flashes, vaginal dryness, mood swings, and she wants fertility preservation. So how are we going to manage this? How are you going to confirm the diagnosis of premature ovarian insufficiency?
Ma'am, she has symptoms of hot flashes, and we will do FSH level also. If with hot flashes, if the FSH level are more than 25, then most likely she's having premature ovarian insufficiency. Otherwise, to confirm,
will you take her history of amenorrhea?
Yes, ma'am, definitely. Prolonged cycles and history of amenorrhea. If it is for more than 4 months, and with that FSH value more than 25, then it goes in favor of premature ovarian insufficiency.
Okay. So if somebody who's only 25 has this premature ovarian insufficiency, what are the consequences?
Actually, first of all, diagnosis is at 25, it is something concerned, and we have to rule out with all the like transvaginal sonography, AMH, FSH, LS, tuberculosis. It may be because it may, we are saying that we have to like differentiate it from Asherman syndrome and the genetic that is a Turner. So chromosomal 225 is too early. Chromosomal karyotyping, everything we have to rule out with the differential diagnosis, and after that, it is not only the hormone level or something we have to take care of. It's like overall genetic issue, inflammatory issue, what caused the premature ovarian insufficiency at that early age, and that also needs a very good treatment according to our workup.
Okay, ma'am. So now her AMH levels are 0.001 and her FSH and LH are above the roof. So what are the consequences of estrogen deficiency in such a young patient? And how are we going to preserve her fertility?
COC will be the best option because she's young girl.
Okay. And
so that regular cycles will be regular, and it will also cover the hormone deficiency part. But if she's desirous of child and are low AMH levels, then she has to go for IVF with donor.
Ma'am, first of all, we have to, there are potential risk of estrogen deficiency. So we have to see for her lipid profile, cardiac status. She has a risk of diabetes mellitus at an early age. And she has risk.
So how long are you going to keep her on COC?
Madam, till she
She's
attains natural
27
menopause.
now.
Till she attains natural menopause, but then she desires fertility. She desires fertility.
Yeah.
So
that
we
can be taken care of by the IVF people.
Yes, ma'am. And after that, till the age of we will give COC, and after that MST.
Now, a patient before you, she has come to you that I'm having extremely irregular periods, and she's 27, and you get these tests done, and to tell her that your natural hormones are over, that has a very great impact. How would you counsel such a patient? How would you counsel such a patient?
She has to accept that.
Actually needs, we need to tell her the fact along with some positive information also. The fact
Actually,
is that fertility can be preserved. I mean, with the egg donation, you can have a child. And these are with COCPs, you can have a normal life. And then what changes you have to do in your daily lifestyle modification. You have to add on these, so that you are not deprived of those things. So, yeah.
Actually, Asha, what you say, we so many times, not only this case situation, obstetric every time. This is something as a very eminent people over here. We say that she is devastated, she is bad, she is gone. But we say it is a medicine is a very truthful science, and it is the basic thing. Be truthful, not comforting. Everything, be it in my and your relationship, be it in a science, we have to be truthful. Make her life plan, what she do. आपके बच्चे हो सकते हैं, वैसे मुश्किल है. It is not naturally processed, but इतनी चीजें हैं जो आप कर सकते हैं. When you will get married, then we will, you have to say and counsel before your thing. So some way you have to say how she is going to manage her life, and give the positive thing that she can live a normal life, what the other woman is doing, because with this support you can have almost parallel to the normal life. And when technology is helpful, few people are reluctant to that, and it's fair enough. So this is something that don't comfort the patient with any false hope, without very high hopes on the technology. Be very truthful. This is something we have to remember, in our all type of clinical practice. Don't see any person is very weak enough. God gives everyone strength, what she has, whatever she has the health.
So it is truth with a sympathetic approach.
All right. So now we go to the next case. This is a breast cancer survivor, hormone positive tumor. She has severe menopausal symptoms. She is 60, but she is now getting severe menopausal symptoms. So, what are you going to do for her? Basic question. What are you going to do for her?
So, ma'am, since she has
I would advise a lifestyle modification.
And?
We can give her... okay. Someone is answering.
Yes. Please, Dr. Babita, continue.
No, you continue. You continue.
Yeah, she's already hormone receptor positive, so I'm skeptical to start her on hormone replacement therapy.
Yeah.
If need be, then I would like to give her transdermal patches. That's all.
The Tibolone can be.
Okay.
No, not Tibolone also. We can give her paroxetine, or we can put her on other SSRI or SNRI. Because
how would
even
you
Tibolone in
assess
cancer
whether she's
survival...
already having a recurrence? She completed her treatment 5 years back, right? How would you assess her recurrence before you start?
We will like to have, before taking anything, you get your latest consultation where your treatment is going on. This is the one thing which we cannot omit. And for these are not two things. One is the hot flashes. So for this, my thing, fluoxetine, gabapentin, that we do. And for local vaginal dryness, it is, I will not give even, I think I am a really skeptical for local estrogen as well, but that pelvic gel, hyaluronic acid, many things are available along with the which we can give, and fluoxetine is a good enough, and along with nutritional and all the psychological thing, because vasometer flushes also always have some psychological component, and when the patient is having a lot of chemotherapy and everything, then they need it, but I will don't give any sort of estrogen.
वो लोग जो ये कह रहे हैं कि पैरेक्सेटिन इस ग्रुप में से दिया सब जा सकता है, लेकिन यूएस FDA अप्रूव्ड पैरेक्सेटिन है.
Fluoxetine, छोड़ो US FDA, it is one of the.
So now we come to the next case. We really need to be fast. We are half an hour late for this program.
Asha, I congratulate you. आपने बहुत difficult questions like case situation दी और ये बहुत मजा आ रहा है.
Thank you. Thank you, ma'am. So एक Turner syndrome की बच्ची है. Okay, she is short. She has primary amenorrhea. She also has osteoporosis. So how are you going to? What are you going to do for her? She is Turner syndrome. Turner syndrome में आप क्या करोगे?
She needs to be started on HRT, ma'am.
Okay.
So because Turner, it's a hypergonadotrophic hypogonadism, and to start her puberty, she needs to be replaced on hormonal therapy. Estrogens has to be started, followed by progesterone. After
you want to give it sequential.
Sequential, yes.
Okay. Anybody has anything else to say?
We can give COCs also, ma'am.
Okay. And what about her bones? Because she has osteoporosis. Yes. She has primary amenorrhea.
Yes.
So one thing that I want to bring to the attention of everyone, that you cannot give ibandronic acid or such drugs when the woman is menstruating. So if you're going to give her estrogen, progesterone and make her menstruate, you cannot give her that. So what is the strategy that you're going to have?
We can give her transdermal patches, and in a sequential manner, then the progesterone at the end of the cycle.
Ma'am, see, the thing is, it's what you're saying is sequential. Whether it is oral or transdermal, that's okay. But you are agreed with the sequential. Dr. Sushma, आप कुछ कहना चाहती हैं? Dr. Geeta, this whole program is for you.
At least calcium and vitamin D can be given. Bisphosphonates cannot be given.
So you are stuck with HRT with calcium and vitamin D.
Yes, ma'am.
And psychological support and monitoring of the patient.
Yes, ma'am.
Now this is somebody who had...
Because she has a risk of developing few cancers, so we have to see for the or do those things also?
This is a 35-year-old who underwent bilateral salpingo-oophorectomy due to ovarian cyst. That is all she knows. You don't have her reports. Okay. She said कि वो ovarian cyst हुआ था तो निकाल दिया. Okay. Now she has estrogen deficiency, hot flashes, mood swings, vaginal dryness. So what are you going to do for her? She has surgical menopause. What are you going to do for her?
Bilateral
You do not have a histopathology report. Remember that. You don't have a histopathology report. And she has estrogen deficiency.
Ma'am, only bilateral salpingo-oophorectomy, uterus is there?
Yes, uterus is there.
Okay. And we do not have the reports. But for young patient doing salpingo-oophorectomy, that must have been really something really serious. It could be malignancy. But then they should have removed uterus also.
No, it's not necessarily it would have been serious. In our country, people are doing it.
No, they haven't removed the uterus. That shows it is not serious. It is just simple cyst. But why have they done such thing? Okay. So,
what are you going to do with her?
We'll give her only estrogen, ma'am.
First of all, we have to reassess
Her uterus is there. The uterus is there. How can you give her only estrogen?
No, we can't give, ma'am. I forgot that uterus is there.
Potential consequences of surgical menopause are dyslipidemia, high risk of CNC, CVD, high risk the patient bone health is also compromised. She is a high risk for.
तो आप उसको HRT दोगे कि नहीं दोगे? Simple. HRT दोगे कि नहीं दोगे?
HRT in this patient, ma'am. We have to give HRT, but we have to assess that, reassess that whether the patient is a case of ovarian malignancy or some simple ovarian cyst. We will try to find out, and we have to
Means
do risk
will
scoring
your
for this.
management differ if she has simple cyst? You have a report that it was simple cyst. Okay. So would your treatment differ? And if she had an ovarian borderline malignancy where both her ovaries were removed and uterus was left because she wanted, fertility preservation?
Actually, in this situation, though the patient might come, what we will like to do when if you have any pre-operative ultrasound report, so that we can say it was endometriosis or it was a simple cyst, what have been, then we will do the TVS and the transabdominal ultrasound again to see whether the ovary are visible or any hydrosalpinx, whatever it is. So when we are okay that it was nothing like very like it was not a borderline or something, because the pre-operative ultrasound and the current ultrasound gives you quite fair idea that the ovaries are visible, what follicle, and then the COC will be there, and we will say
okay. So even in such a case, you are giving her COC till she attains the age of menopause. अब एक और नया scenario जो अपने यहाँ बहुत common है. 52-year-old, she started self-administering HRT from an online source without medical supervision. She presents with symptoms of estrogen excess, including breast tenderness, bloating, mood swings. Now she also has high blood pressure and hypercoagulable blood. So what is the potential risk if there is an overdose of HRT?
Thromboembolic events might be more.
She still hasn't had that event, right? She has those breast tenderness, bloating, mood swings, all that is there.
So all the risks which we are fearful to give HRT, all the things why we are having that something, all estrogen, endometrial carcinoma, increased risk of breast carcinoma, all the breast disease and the thromboembolic coagulability. And one thing is this, that you say it is very common in our
taking only estrogen. See, she is taking estrogen replacement therapy. It is online. It is online now. Online se manga liya aur kha rahe hain.
We are very fortunate that actually we don't get till now they are not getting that online. It is more common in the Western.
Madam, they are getting it. They are getting it.
Yes, they are getting it.
They are getting it.
In metro countries. We're not in
Now we have 45-year-old again taking HRT because her friend was prescribed, so she looked at it and she started taking the same thing. Now she has symptoms of estrogen deficiency, hot flashes, night sweats, vaginal dryness. She also has menstrual-like bleeding and endometrial hyperplasia. So if you're doing unsupervised, unauthorized HRT, how are you going to counsel the patient? How are you going to look at her endometrium and how are you going to counsel her?
We have to tell her what she was doing was wrong, and obviously we have to well, this is what counseling has to be.
And now you have to do a detailed assessment of all the factors, like all the
You have to
factors.
assess her endometrium by a transvaginal ultrasound, a DNC, and if there is endometrial hyperplasia, whether it is typical or atypical, and her chances of endometrial carcinoma also.
Yes, ma'am.
Okay.
And even other factors also, like hypertension, dyslipidemia, I mean, all the risk factors
we have discussed that. This one is focused on the endometrium.
Okay, ma'am.
So now this is 58. She is 58 and she is self-administering HRT for 1 year. She has problems of estrogen deficiency, hot flashes, and vaginal dryness. Lab tests revealed elevated estradiol levels and suppressed FSH. Okay. E2 is raised and her FSH is low. So what are the dangers she is in? What is the danger that she is in?
Danger hai.
Endometrial carcinoma, ma'am.
और फॉर्चुनेटली हम लोग के पेशेंट मेडिकल अबॉर्शन लेते हैं ओवर द काउंटर, पेन किलर लेते हैं, कभी कभी एंटीबायोटिक, बट वी आर वेरी फॉर्चुनेट. आई थिंक बबीता यू विल एग्री दैट वी डोंट गेट द पेशेंट who are taking self-administered HRT. So it is a blessing and something. One I will say one thing because you say ना एक चीज हम लोगों को भी बहुत सोचना चाहिए, मतलब which I always say that it is very, very important because social media and everything is putting a lot of stigma over menopause. Woman has not ever been in any life or man synonymous with estrogen or synonymous with testosterone. Every person is a full human being. It remains right from the day of birth to the day of death. And why the people are taking on these HRT? Because a lot of social media offensive advertisement with the pharma that they are making menopause a disease actually. And we have to be very aware of this fact that India and South Asia have got entirely different perspective when we look towards menopause, and we as a doctor should carry that positivity along with this. So estrogen deficiency is one thing, but nature, like we say, calcium deficient, more calcium absorption. Nature has got its own way for the parallel estrogen production. So it is a little bit of it. Everybody, we once upon a time, abhi social media ka pressure hai, ekdam up rahiye, ekdam seek silai. But we have the alternate source of estrogen if it is in a good time. Adrenal secrete estrogen, a little bit fat is secrete estrogen. So I say, Asha, because it is your program, that's why I'm saying it from my heart. No age is a synonymous of disease or something. Every person is full of like a health, just we have to tailor and we have to take that positivity what our reason have for the menopause as we look at it. So it is all about, and we are very fortunate because US mein, like what is they are taking DHEA pill, what we give now for low responder for increasing libido at 60 years, and they're popping it up DHEA. So something we have a lot of positivity. और हम लोगों को बहुत सतर्क इसलिए रहना है बिकॉज 50-20 साल पहले गोरखपुर रायपुर के लोग नहीं जा रहे थे, बंबई में लोग कैसे रह रहे हैं, पूना में कैसे रह रहे हैं. नाउ दे आर एक्सपोज टू यूएस एंड एवरी वे, एंड इट इज हाई टाइम दैट एज ए डॉक्टर वी ऑल्सो हैव दैट स्ट्रॉन्ग वॉइस what is meant by good health at every age. It is be it a menopause or whatever it is. And I think I have
Thank you, Sadhna-di. Thanks a lot for that. I request everyone here to give a one-liner take-home message, and then we can end the session. I'm so grateful. We are 45 minutes beyond time, but we have enjoyed it. And thank you for the encouragement for saying that the cases were good. I really make a lot of effort for them.
Cases were very interesting.
Yeah.
We had to read up a lot.
And very different panels, ma'am. It's got a very different panel.
Thank you. Thank you. So I just want one liner from everyone, please.
And
Meeta
my
ma'am,
message is,
you go first.
okay.
Meeta ma'am.
Yes.
Yeah.
So congratulations, Asha. I think that was wonderful collection of cases, and your panelists, everybody did a good job bringing about different aspects. So the one-liner is, I agree wholeheartedly with what Dr. Sadhna said. And I think that is the punchline, that hormone therapy is not for everybody. It's only about 8 to 10% of the Indian women probably would need it. So 90% of the women don't need hormone therapy, but the women who need it really need it. So we doctors have to be geared up to look after those 9 to 10%, because the rest is all about, the other modalities that we would need. Thank you for having me in.
Thank you, ma'am. Thanks a lot. Sadhna, ma'am? Dr. Sadhna Jaiswal, ma'am?
Sadhna, you. I have said.
Yeah. For menopausal women, I would say you must pursue your hobby at this age, and there is no age for learning. Keep learning new things. That's my take-home message.
Thank you. Thank you. Dr. Chanchal?
Ma'am, I would like to add, I am a laparoscopic surgeon. So I would like to add, prevention is better than cure. Please avoid unnecessary oophorectomies, avoid surgical menopause. That should be a take-home message.
Thank you. Dr. Geeta?
Madam,
How did you like the session?
Very nice, madam. Very useful. I'm so thankful to you. God bless you.
I just want to share one story. My mom, so personally, I have seen in my life as well. So I am a great, I don't remove ovaries in cases till 50. And I always recommend, even patient is insisting, then also I don't remove ovaries.
Okay, thank you. Yes, Dr. Geeta?
And I would say we should start exercise when you're around 50 at least. If you do moderate exercise, then sarcopenia can be prevented. So a little bit of happiness will be there, and the pains and all will get reduced along with this MHD.
Thank you. Thank you. Dr. Babita?
Yes, ma'am. Menopause is the time when we have the empty nest syndrome and we have bit mentally disturbed. So make as many friends as you can and be very active socially. I really love making friends. That's why I'm saying this.
Thank you. Alpesh, sir?
It was very excellent and informative. I enjoyed it a lot. Thank you.
Thank you, sir. Any take-home message?
We should always try to learn as many as things. HRT is a newer thing for us.
Thank you, sir. Dr. Alpana, you are there? Dr. Priyanka, you end with your punchline.
Thank you, ma'am. Thank you for the opportunity. It was really a very great presentation and discussion also. And from my side, the take-home message is lifestyle therapeutic medication is very much necessary. Thank you so much, ma'am.
Thank you. Shobha has walked off, so thank you, thank you, thank you. I have no other words to say. Such bigwigs have come here and they've stayed along for such a long time. I'm extremely grateful to everyone. Thank you so much.
Great learning also. Yeah, great learning for us.
And thank you for making us a part of such a wonderful panel. We are feeling so happy.
Best wishes, Asha, for your election, upcoming election, and we
thank you.
We are
Our
all
society.
behind you. We are all
Kannur
behind you.
society
अब
will
सबका
support.
support चाहिए करबद्ध प्रार्थना.
Kannur society will support you,
Sure,
ma'am.
ma'am.
Don't worry.
Thank you, ma'am. Thank you. So thank you, everyone. Sadhna Di, Meeta ma'am, Sushma, Dr. Geeta,
It was a wonderful program, ma'am. Really enjoyed. All the lectures were very nice, very elaborate, and the panel is very based on very practical questions that we face in day-to-day practice. And I am really thankful to all the.
So, Bhai, आपका last point रह गया. One take home from your side.
Take home? Yeah.
Yes.
That is wonderful. I got up to serve my husband dinner, so what to do? Can't help that. वो भी करना पड़ता है ना साधना? वो साधना जी, वो भी करना पड़ता है. It's lovely to connect with Dr. Sadhana today also. And I missed Dr. Meeta's last message. Anyway, I feel that whenever there is a doubt in your mind whether to prescribe or not, remember that the woman will benefit more often than not with menopause hormone therapy. That is what I wanted to convey, because if you look at the spectrum of women coming into your clinic on an average, most women can be safely prescribed menopause hormone therapy with a good indication and with good, the goals of therapy and structured follow-up, and we can always remain within the safety zone. Develop the courage to prescribe. That's all.
Thank you. Thank you. Sushma, you want to give the vote of thanks? Official vote of thanks? You're muted, dear.
Okay. It was a very wonderful webinar, and I suppose Dr. Asha Jain Madam has well planned it and well kept all the topics were very practical. So on behalf of Cancer Prevention and Relief Society and Searchlight 15 webinars team, I want to thank all of you, all the participants as well as the delegates of the webinar. And from bottom of my heart, I want to thank our chief guest, Dr. Sheila Mane ma'am, and our guest of honor, Dr. Anju Soni ma'am and Sudha Sharma ma'am, for taking out time from their busy schedule and blessing us on this very important occasion. With lots of respect, we want to thank our expert speakers, Dr. Shobha Puri ma'am, Dr. Meeta ma'am, for their elaborate lecture and sharing their insights with us. And with gratitude, we want to thank our respected chairpersons for their wonderful insights and their active participation in the whole webinar. With great respect, I want to thank our moderator, Asha Jain ma'am. Definitely, she has planned a very nice panel, and the expert Sudha ma'am for her very perfect comments on the questions, and our respected panelists for the brainstorming and great panel discussion, which is based on practical tips.
Thank you, Corona Remedies, for being with us today. Thank you. Thank you so much. Namaskar, Shubhratri. See you again next Wednesday. Yesterday, I was giving my IFCPC exam, so I had to shift this to a Thursday. But otherwise, Searchlight is always Wednesday evening 5 to 7. See you again in the next webinar. Namaskar. We are dealing with monochorionic twins and complications in the next webinar. Thank you. Aditya, may I
all the best, Asha, for everything. Wishing you all the best for everything.
Thank you, Didi. Thank you.
Yeah.
And last, ma'am, at last, I want to thank Core Connect team, Corona team, for their regular participation in this webinar series and providing us an academic platform. Sorry for interruption, ma'am. My network got shut down.
Okay.
And thank you very much.
Everybody has to log out because the Corona team is not there anymore. So we all have to just leave the webinar. Thanks a lot. Thank you. Good night.
Thank you, ma'am. Thank you very much.